if it bubbles within that person's respiratory tract, that means you can easily change these pathogenic molecules from being that heavy because you're taking away the moisture content around them and they become airborne. So that's the reason why whenever you are handling aerosol generating procedures, you should be dressed in appropriate PPE to protect you in that regard. As opposed to where you are in the general pool of patients, where you do not expect that you're going to be generating any aerosols, that you can use droplet infection prevention mechanisms that we've talked about. For as long as you have an N95 mask, face mask, and you have visors or a face shield or goggles, and you have a gown that can protect your linen, and I mean your scrubs and your skin, that can be appropriate enough. All this will come in the infection prevention and control presentation at a later point in time. So I wouldn't wish to dwell so much into it. So this is the algorithm that we use when we are screening and allotting patients a pathway into the healthcare facility. How do we take patients through the healthcare facility? Presently, what we are advocating for is a unidirectional flow of patients and healthcare workers, as opposed to the by flow, where someone moves in and out in the same area. In that regard, we are able to prevent an easy mix-up of patients and healthcare workers, which could expose us to infections. So when a patient enters, I think let's go through this slowly, because it's very important for us. So when a patient is going to be expected of us is washing, because our hands are potential carriers of the pathogen. Why? Many of us have not yet adopted the ideal cough etiquette, where we cough into our shoulders. Many of us still cough and sneeze into our hands. So meaning that when someone sneezes or coughs into their hands, they actually inoculate their hands with the pathogens. And exchange of hands, if they've not washed them, to break that chain of transmission, they can end up spreading the infection from one person to another. So that's why hand hygiene is very critical. And that's why it should be the starting point at the entrance, not even the screening or the temperature screening, but rather hand hygiene. And by hand hygiene, we mean not having stations that are there for cosmesis or for pictorial compliance, but rather functional hand hygiene stations. Dr. Nagudi, through you, I do not know whether that hand hygiene station is functional. I was not subjected to it. And I did it on purpose just to see whether I would actually be subjected to it or not. And none. No one could do it, which was not proper. I'm sorry for being hard, but it's what it takes for us to break the chain of transmission today. Yeah. Then we need to be able to take the temperature of a person immediately they are arriving at the facility. Why should this be taken? We have noted that majority of the people that are presenting with COVID-19 have a raise in their body temperature above 37.5 degrees Celsius. So when someone presents with a temperature, and actually the first case that we detected as a country at the airport on March 21st, 2020, it was through temperature screening. And it was upon the people that were manning the station taking Secondly, that temperature should be recorded in a log with the person's name and contact for ease of follow-up, should there be any need for follow-up. 3, we expect that there should be someone that routinely reviews this record and makes sense out of it. Whether we are having any people that are coming into our premises with suspicion of COVID-19 or not. Otherwise, if we take it as a routine and people continue doing it, an adult mind will only do something that it deems relevant to it. For as long as we lose the relevance for which we are doing the temperature screening, people will continue doing it as a routine, but when actually it's not helping us in any regard. So we should be able to make meaning out of what we do so that people can actually continue doing it with a purpose. If a person presents with a temperature that is 37.5 and above, or have a fever by feeling, and they have signs and symptoms as cough, shortness of breath, muscle pains or weaknesses, a sore throat or a headache, this is going to be a person that should be treated as a suspect and therefore should be followed up in this order as we. Chair, I do not know whether I can continue because the screen is off. I don't know whether I'm being heard or being seen. Oh, okay. So I can continue? Yes. Okay. Are members supposed to interrupt and ask questions or they wait? We have a Q&A session at the end of it. Yeah. They can post in the Q&A. Yeah, they can also post on the chat. Okay. So if a person presents with these signs and symptoms as have been demonstrated above here, a temperature above 37.5 for people that have temperature guns at the entry stations, or a person that is reporting a fever, or a person that presents with a cough, shortness of breath, muscle pains, a sore throat or headache, this person should be treated as a suspect and therefore should be at that particular point in time, if they do not have a community mask that has been provided unto them, should be provided with a mask before they can access the facility for further attention. And if a person does not have any of these signs and symptoms as have been reported, then they should be allowed into the facility and they go and seek for their care as required. So for a person that has been found to be a suspect, how do they flow through the facility? One, we have to assess whether their symptoms that they're presenting with are fit to be regarded as danger signs or not, so that they can be accorded appropriate care. Remember, I said early detection, early intervention, good outcomes. Late intervention, poor outcomes. So if a person is having shortness of breath, or if a person is having difficulty in breathing, then this is a person that is fit for stabilization first before they can proceed to be attended to in any other regard. So you need to be able to put these people in the holding facility that we've talked about. And this holding facility should be well aerated, and it should be fitted with all the PPEs that we've talked about, that they do not expose the healthcare workers to infection. Remember, we are a very limited resource. And therefore, if we keep exposing ourselves as healthcare workers, that means we are going to deplete ourselves, and tomorrow we will have no people that can manage the response. So we need to protect ourselves before we can protect others and before we can serve others. So if they've been stabilized, then they can go ahead and have all these other interventions undertaken. One, being screened for malaria, which is the leading cause of fevers amongst our population. And then they should also have a COVID-19 test that should be done at that level. We are lucky that we are now using antigen RDTs, but if this person tests negative for antigen RDT, on antigen RDT, that will not exclude positivity for COVID-19. Therefore, they should be exposed to a PCR test hereafter. So the danger signs that we're looking out for here are people that are going to be having rapid breathing, that is greater than 30, more than 30 breaths per minute for adults, then more than 40 breaths per minute for children that are aged 1 to 5 years, and more than 50 breaths per minute for children aged less than 1 year. Then people that are having difficulty breathing with extramuscular involvement, like people that are going to have intercostal recession, people that are going to have disorientation, and people that will have sunken eyes, as well as inability to drink or eat, would be looked at as people that are ill, that warrant to be stabilized first before they can proceed for care in the facility. Then upon doing these tests, then we should be able to determine the level of risk of development of severe forms of the illness that this person presents with. And if a person does not have any danger for development of severe forms of the disease that they're presenting with, then they should be admitted in the isolation facility, and they should be stabilized at that level in that holding facility before they can be allowed out of the facility. But if they have signs and symptoms that are proving to be a danger to their lives, meaning that if they were not attended to, that can prove a risk to their lives, then they should be stabilized at that level of the facility where they are screened from, and they should be admitted to a higher level that has been gazetted to manage COVID-19 with clear isolation protocols. So it's at this level that we are determining people that are fit for home isolation and people that are fit for admission into mainstream COVID-19 isolation facilities. So in triaging, we are basically doing one key element of sorting and prioritizing patients based on their severity of illnesses. And it's by this that we are able to use standardized triage tools to ensure reliability and validity of sorting of patients. So in triaging, we try as much as possible to avoid under triaging and over triaging. What do we mean by under triaging and over triaging? Under triaging is where you look at signs and symptoms someone has presented with, and you take them for granted, and you do not accord them the appropriate care or level of care that they should get, and that exposes their lives or their health to danger because they can easily deteriorate. What we have noticed with COVID-19 is we have people that we're calling happy hypoxics. A person comes when they are very stable and they do not have any trouble. But when actually they are desaturating, by desaturating, we mean their oxygen saturation, their oxygen levels in their blood and their tissues are much lower than what is compatible with good health. And if such a person is not well attended to, and we take it for granted that after all, he came in walking, and therefore, when we do pulse oximetry and we find his saturation at say 85%, we imagine that he can do with it. That is a time bomb in waiting, because that person can easily tip over, and it becomes very difficult for us to pull them out, because you cannot know the extent to which his lungs have been damaged or destroyed that will warrant correction or support, and you may not be able to manage it at that level. So that's why it's important for us to triage patients appropriately, so that we can be able to accord them the necessary care that they deserve. And over triaging is where you become so over enthusiastic and you do things that are not warranted. A person that is fit for say maybe mild or moderate classification, you classify them as severe, and then you go ahead and intervene aggressively. We've also noted that mechanical ventilation per se is not very good. So you only do it when it's indicated, and therefore we try as much as possible to give people their appropriate classification of their conditions, so that they can be able to get the relevant and necessary care that is warranted for that level of illness or disease that they have. So in this, we have the categories of patients that we have when we are talking about COVID-19. One is a person that would be classified as mild disease, moderate disease, severe, or critical disease. And in mild disease, this is a person that is going to present with signs and symptoms consistent with COVID-19. But when you look at their parameters, they are saturating well above, say, 95% on room air. The fever they have is between 37.5 and 38, and can easily be controlled on use of simple antipyretics like paracetamol. They have simple pains, body pains, and they just don't feel fine. They are presenting with signs and symptoms consistent with COVID-19, but the conditions that they're presenting with are not life-threatening, and therefore they are classified as mild disease. We can also have these people presenting with no any signs and symptoms, but when actually they have a positive COVID-19 test. So those are the people that we treat or we take as asymptomatics, and those are the people that are mandated to be managed under home-based isolation and care. The asymptomatics and people with mild COVID-19 disease. For as long as a person has moderate disease, that is not a person to be managed under home isolation. If I may tune this discussion to what the administrators of the institution said, that we are talking about home-based isolation and care. Similarly, we can have people under mild, classified under mild COVID-19 disease, but when they have comorbidities or underlying diseases that predispose them to development of severe forms of COVID-19. And these are people that will have hypertension, people that will have diabetes mellitus, people that will have renal disease, people that will have other respiratory conditions like bronchiectasis, people that will have chronic obstructive pulmonary disease, people that have TB. Those are people that, much as they will have signs and symptoms of COVID-19, that would classify them as mild. That should not be treated in the community because they are at risk of developing severe forms of COVID-19 anytime, and therefore they should be taken into a gazetted COVID-19 treatment unit, stabilized and discharged when they are stable before they can be reintegrated in the community. So for people that are having mild COVID-19 disease, majorly what we do here is supportive treatment or therapy. And if a person is presenting with a fever, what is expected of us is to manage the fever. So we do symptomatic therapy or management. And we give them zinc, 20 milligrams once daily for the adults. And then the presentation will be shared with us in summary. So, yeah. So then presently we give them vitamin D, and all these have been postulated as immune modulators, as vitamin C is presently coming out from the guidelines. In the previous guidelines, under the second review, we had vitamin C for every person that would test positive for COVID-19. In the revised guidelines that should be exited anytime soon, vitamin C is coming out and we are having vitamin D coming in. Vitamin C is out for adults, but it still remains for children. I need to make this clear. Vitamin C comes out for adults, but it remains for children. So these guidelines will be shared with us at the end of the discussion today so that we can be able to compare notes. So for children, we give them paracetamol, just like the adults, and then we calibrate it to their body weights, and it's given as an 8-hourly dose. We give them vitamin C, we give them vitamin D, as well as zinc. Zinc helps us in the improvement of the integrity of the intestines. Remember, we talked about, or any other luminal structures, organs in the body. Remember, we talked about diarrhea, nausea, and vomiting in some instances. So for people that present with diarrhea, when you give them vitamin C and you improve luminal integrity, or you improve the lining of the hollow structures in the body, then you tend to minimize the degree or the extent of injury that the COVID-19 virus causes at that level of the organs. And you improve function of those organs. Because remember, what we're talking about in COVID-19 is multiple organ engagement or involvement, which fail, and eventually you find people presenting with all these conditions that we see in the hospitals. So the medicine that we're giving is supportive to make sure that we improve the functioning of those organs, such that even if at the insult of the virus, those organs continue functioning, and therefore we improve the outcomes of these people. So for people that have moderate disease and are classified as simple bronchopneumonia, if they are adults and they are having fast breathing of 20 breaths per minute or more, but are still at normal saturation on room air, these people should be subjected to a chest X-ray. And the chest X-ray in this regard, we are going to be looking at the extent of injury of the lungs as a factor of infiltration or exposure to COVID-19. So if a person is breathing fine, what we're going to be required to do is manage the symptoms that they are going to be presenting with at that point, and make sure that we monitor them, majorly monitoring their oxygen saturation to keep it above normal, which is, or to keep it within the normal ranges, that is 95% and above, and make sure that we minimize progression to the severe forms of the disease as much as possible. So if it's going to be a child that is going to be presenting with more than 60 breaths per minute for the age category of less than 2 months, or more than 50 breaths per minute for the age category 2 to 11 months, and age category 1 to 5 months, 1 to 5 years of 40 breaths per minute, then these are children that will be treated as moderate disease, and therefore they should be given treatment therapies for moderate disease rather than severe forms of COVID-19. So what do we give children that are being managed for moderate disease? The guideline that has been developed with input from several senior colleagues that have expertise in respiratory tract pathology state that children less than 5 years should be given oral amoxicillin if they can take orally. And for children that are above 6 years but are less than 12 years, should be also given amoxicillin. And we only give supportive therapy of zinc, vitamin A, vitamin D, and vitamin C. This is an improvement. It's going to be in the guideline, it's captured very well. Then we need to be seen to monitor children or people that are presenting with mild and moderate disease. And what we monitor for are temperature. Remember, we said COVID-19 presents with a rise in body temperature. So if a person's temperature is above the normal, we should be seen to be doing something to correct this temperature back to the normal range so that they can be comfortable around themselves. Then mental state. COVID-19 has come with a lot of psychosocial issues. In the initial phases, there was victimization and stigmatization. Whoever presented with COVID-19 was taken as though they were social outcasts, and that tended to separate people from society, and it raised aspects or concerns of psychosocial issues or psychosocial nature. And by that, we should be seen to address people's psychological issues or concerns, what their worries or fears are, and then we attend to those fears so that we can allay their anxiety and improve their outcome of personal performance. Heart rates tend to go up because of a diagnosis with COVID-19. And with the latest events that we are seeing, where most of the people that are presenting with critical disease are actually succumbing, so many people are afraid of a diagnosis of COVID-19. Once someone is told that they are positive for COVID-19, what we have seen is even those that previously did not have hypertension, they come to hospital when their blood pressures have raised up because they are anxious. So we should be seen to normalize that, talk to people around their condition, stabilize them, and make sure that they understand what exactly it means for them to have a positive COVID-19 result. Then we should be able to do laboratory tests for people. In this, we look at majorly a complete blood count. It should tell us what exactly is going on. We've seen people that have COVID-19 presenting with a reduced level of platelets. And that is one thing that we should be able to monitor. And more so, if a person progresses to severe forms of COVID-19 and they necessitate to be given anticoagulants, you would wish to understand what the baseline or what the normal level of someone's platelets were before you can subject them to anticoagulants. Otherwise, you can cause a bigger challenge than you are solving. Then we need to look at also their blood levels and correct them as appropriately as possible. And then we also need to look at their liver and renal functioning by doing that serum, by doing those laboratory tests that target majorly the lung, the liver and the kidneys. And in that, you're looking out for particular enzymes of the liver. How are they performing? When you're doing the renal panel, or when you're doing the renal function tests, you need to look out for how they are functioning at that level, such that it can give you a baseline against which you are going to act later in the future to determine whether they are actually getting into what we call renal disease or renal failure as a factor of the exposure to COVID-19, or they are remaining stable. Otherwise, if you do not do a baseline, then it becomes very difficult for you to determine whether that person actually, if they later on develop renal disease, it becomes very difficult for you to determine whether they actually came with their renal disease or the renal disease was as a result of their exposure to COVID-19 as a complication. Similarly, their liver functions. You need to understand what their baseline is before you can intervene, such that you have a baseline against which you're going to be working to restore this person's life later in future. Then we are no longer doing repeat PCRs for people that are presenting positive with COVID-19. It was in the first wave where we had repeat PCRs being done to determine whether people had cleared the virus from their bodies or not. But with more research, it has been established that after 10 days of exposure to COVID-19, with the initial strain that we had, after 10 days, you'd have a clearance of the virus from someone's body. Meaning that if someone was asymptomatic or had mild disease with a few signs and symptoms, and those symptoms resolved within that period of time, then it would be assumed that that person has actually cleared the virus. But new information is emerging with the new variant strains that we are having, especially the Delta and the Gamma strains that we're having from South Africa and from India, that are taking much longer to clear from the body. So that information will be available to us once the studies have been concluded. For people that present with severe forms of COVID-19, that is for adolescents and adults, one, we need to be able to understand what exactly secondary to the difficulty in breathing they could be having as an underlying disease infection that they are presenting with. We all appreciate that viral infections expose us to secondary bacterial infections. So we need to be able to determine what secondary bacterial infection this person has, so that we can be able to structure an appropriate antibacterial or antimicrobial agent to improve this person's outcome. So that's the reason why the first thing that we should be seen to be doing is if a person is having reduced oxygen saturation in both their blood and their tissues, we should be seen to be correcting that by giving these people oxygen that is supplied from either concentrators, from cylinders, or from the piped oxygen on our walls. And this calibration or titration is determined or based on the level at which a person is saturating. You do not just give it as a one size fits it all, as a one size fits all prescription. Every person will have their own different oxygen need and demand, and therefore that titration calibration should be based on someone's need. If a person is desaturating and they're at 91%, we know the normal should be above 95% on room air. So if a person comes and they are saturating at 92%, they are below the normal, but not so much below the normal. Therefore, you should be able to calibrate and titrate the oxygen level to be able to correct that difference or that gap so that they can be able to get back to their normal of above 95%. And as you're correcting that, you should be seen to also correcting the underlying cause of the desaturation, so that at the end of the day, as you take away the insult, a person's health is being restored so that they can be able to breathe on their own. So for children that will have cough or difficulty in breathing, we have to, or they have features of reduced oxygen in their tissues by what we call central cyanosis, where you'll have children's extremities, the fingers, the palms, and even the soles, and even their bodies, or maybe the lower surfaces of their eyes turning blue. That means you're having a high volume of deoxygenated blood. Okay, you're having a high level of deoxygenated blood in the system as compared to the blood that has oxygen. Then you should be able to intervene appropriately and restore that status by giving people oxygen from external support. So what do we use in determining the extent of severity of the infection that someone is presenting with? One, we use what we call the severity scores that can be guided by several mnemonics. One, we look at the status of the mental status of a person that they're presenting with at that level. If a person has a state of confusion, and when we do their renal function tests, we find them having a urea concentration of greater than 7 millimoles per liter. And then on physical exam, they are having a respiratory rate of more than 30 breaths per minute. And when we do their blood pressure, they are having a systolic blood pressure of less than 90 millimeters of mercury, and a diastolic pressure of less than 60 millimeters of mercury. And their age is greater than 65 for the adults. And then this person is going to be taken as having severe forms of COVID-19, and therefore should be managed in a facility that can accord them the appropriate care. And the facility that can do this is one that has a high dependency unit level with capacity to escalate to intensive care unit, because you cannot determine the extent of injury to this person's lungs, meaning that anytime they can deteriorate and warrant you giving oxygen by other mechanisms other than just giving them oxygen by the masks that we put onto people's faces, what we call the non-rebreather masks that have got different, all this will come in the oxygen therapy presentation, where we have different levels of, or different oxygen delivery tools, starting with the nasal prongs to nasal cannulas or non-rebreather masks. Then you can end up with high nasal flow cannulas, and then you can end up also doing what we call oxygen delivery by intubation, where you insert a tube or an endotracheal tube into someone's lungs and make sure that you start breathing for them practically as you sustain their bodies, but then also as you correct the insult that has been exerted onto someone's lungs so that they can start breathing on their own. So for scores that are going to be 0 to 1, these are people that will be at low risk of death, and therefore they should, this can be treated at home if a person wishes so. A person that scores 2, this will be a person with a moderate risk of death, and therefore should be managed in the hospital setting that has both HDU and ICU capacity. And a person that scores 3, and above, that means this person has a high risk of succumbing to COVID-19 and therefore should be managed in a high-level, high dependence unit or an intensive care unit for that case, if it's available. So this is what we are looking at in scoring. You're looking at confusion status. You're looking at urea. Urea is a good marker of kidney function. And then you're looking at the respiratory rate, which is a very good marker of the ease with which someone is actually able to take in oxygen and utilize it for their cellular function or tissue function. And then you're looking at their blood pressure, which is a clear function of how the heart is responding to how much oxygen you are subjecting the body to. So these are the national early warning score signs that we look at, and we help score our patients and therefore determine the risk of their progression to severe forms of COVID-19 and their risk of mortality, so that we can be able to accord them appropriate care. One, we look at the scores from 3, -3 to 3. And in this, we're looking at respiratory rate, we're looking at oxygen saturation, and we're looking at oxygen when they're given oxygen, either on room air or supplemental oxygen. And then we look at their blood pressure, systolic, and then we also look at their pulse rates, level of consciousness, and their body temperatures. So if a person is going to score less than 8 breaths per minute and more than or less than 91% on oxygen saturation, and they are on room air or they are not on any form of supplemental oxygen with a blood pressure of less than 90 and a pulse rate of less than 40 with a temperature less than 35 degrees Celsius, what we call hypothermia. This is a person that is going to score 3, and that means this person is at great risk of death. By any measure, this person should be managed in an intensive care unit so that we can be able to breathe for them and give them oxygen that is relevant for their tissues, and then give them the relevant fluids and corrective therapies that can restore their lungs and their heart functions. Can I go through it all, or we proceed? Because this is going to be shared with us. Okay. I have taken a long time. I'm sorry about that, but it was very important for us to understand these basics. So clinical response to the news that trigger thresholds. So if a person has a total of 1 to 4, that is monitored 4 to 6 hours, then this person should be monitored continuously, and we should be able to inform the resident nurse who must assess the patient at this interval for us to be able to take an appropriate response. And the response, the resident nurse should decide whether the increased frequency of monitoring should be activated or not, and if it should be escalated or it should be it should remain at the same level. Then if a person has 3 in a single parameter, then by 3 in a single parameter, we mean this. If a person has a respiratory rate of less than 8, then oxygen saturation less than 91. If you have any of these 3 parameters scoring 3, then you should be monitored every after 1 hour. Why every after 1 hour? To be able to improve your outcomes so that we can be able to take interventions as of when there is need, because this is a person that can change condition anytime and therefore should be monitored as closely as possible. If possible, this is a person that should actually have a person standing by that can easily detect any change in condition and therefore intervene. If a person has a total of 5 or more, then there is an urgent response threshold that is triggered at this level, and this person should be monitored for more than one time in 1 hour. And these are the actions that the resident nurse should be able to undertake. They should be able to inform the medical team that is caring for the patient on what exactly is happening. Then they should be able to request for urgent assessment by the physicians or the teams that are managing the patient. In the ICU, it's usually a multidisciplinary team that manages the patients they are in. So depending on what the patient is presenting with, that team should be informed, and therefore that person with the special skills invited to come and review the patient as of when necessary. Then there should be need to provide clinical care in that environment with monitoring facilities, and this is a person that should be managed in the ICU. So if a person has a total of 7 or more, then this is what we would regard as emergency response threshold, and this is a person that should be monitored all the time. So the medical, it sees as being the resident nurse alone, but on top of the resident nurse, you add a medical officer that should continue monitoring and managing this patient. And this patient should, the emergency team should be able to inform the whole entire multitask team to come and appropriately respond when need arises. So this we've already gone through. So in management of patients that are in the ICUs or people that are presenting with severe and critical disease, we have people that will present with majorly sepsis that has to be attended to. And with this, we will assess for organ dysfunction and be seen to correct the organ dysfunction. If a person has altered mental status, we would wish to understand what exactly is causing the alteration in the mental status. Is it an electrolyte imbalance that's causing that? Or could it be anxiety? Could it be some fears that the patient could be having? And we should be seen to address that. If a person has difficulty of fast breathing, is their oxygen concentration lower than what the normal should be, and therefore they are struggling to breathe or struggling to sustain themselves, we should be seen to assess that and therefore correct it. Urine output is a key indicator of kidney function. If a person has not produced the requisite amount of urine in a 24-hour day, that person should be assessed for kidney injury or kidney failure, and appropriate interventions instituted. If there is need for dialysis, dialysis should be instituted so that someone's excretion is corrected. Then if a person has cold extremities, it may be a factor of reduced blood pressures that need to be balanced out so that someone can be restored. So for children that will present with sepsis, that was a fever of more than 38 degrees Celsius or less than 36 degrees, a heart rate of more than 90 beats per minute, and a respiratory rate of more than 20 breaths per minute, with an arterial carbon dioxide tension of less than 32 millimeters of mercury. This is a child that will be regarded as having sepsis in COVID-19, and therefore should also be treated as we have seen the treatment for the adults here. They should be evaluated for organ dysfunction, and the organ dysfunction, the particular organ dysfunction attended to and corrected. Okay. So in acute respiratory distress syndrome, what we are looking out for here is recognize the severe hypoxemic respiratory failure signs when a patient is with respiratory distress, and therefore describe the appropriate oxygen therapy levels or concentrations to correct that. If trained and experienced providers are available, that is intensivists or critical care specialists, then these are people that should be intubated and provided capacity to breathe mechanically. And then if in patients with severe acute respiratory distress syndrome, then they should be given prone ventilation for more than 12 hours, which should help improve their lung function. And then we should be able to use conservative fluid management strategies for people that are going to present with acute respiratory distress syndrome, because there can be a challenge of a fluid overload that can end up causing more trouble than is good. So for the critically ill COVID-19 septic shock patients, what is going to be required of us to do is make sure that we correct the hypotension that they will be presenting with. Then we correct the hypovolemia by resuscitating with requisite fluids, preferably colloids, as opposed to other parenteral fluids. And if need be, when their blood pressure still remain low, we should be seen to be giving them vasopressors. And the vasopressor of choice that is recommended by the national guidelines is noradrenaline. And we should be able to make sure that we maintain them at a blood pressure of, an arterial pressure of greater than 65 millimeters of mercury, with a serum lactate level of more than 2 millimoles per liter. And for children, the presence of the 3 clinical criteria required to diagnose shock should be screened out for, and that is delayed capillary refill of more than 3 seconds, cold extremities, weak and fast pulses, and then frank hypotension, where you look at the different age categories. If a child is less than 1 month, the frank hypotension or the age-related systolic blood pressure will be less than 50. For children aged 1 to 12 months, the systolic blood pressure that is looked at is of less than 70 for them to be diagnosed as having septic shock. And for those that are 1 to 12 years, you look at a blood pressure of 70 and below. And then for those that are 12 years and above, you look at a blood pressure of less than 90 millimeters of mercury. So the clinical features of shock in children that we look out for are mental status alteration. Children will be irritable, they'll have inappropriate crying, and then they'll be confused, or they'll have poor interactions with their mothers or their attendants. And then they'll also be drowsy, they'll have weakness that cannot easily be aroused. And then when you look at their capillary refill, a capillary refill is when you press the end of a digit. It can be either a toe, a thumb, or the heel of the child's foot. If you displace blood from those tissues, you watch out for how long it takes for blood to fill back in those tissues. If it takes longer than 3 seconds, then that child is going to be taken or regarded as having septic shock. So how do we manage septic shock? For adults, depending on what your renal function tests will be reading, if they have a very low potassium level, you'll be required to give them Ringer's lactate or normal saline if their sodium levels are low. But the fluid of choice majorly is a colloid. And for children, we'll be required to give them normal saline still or Ringer's lactate, and we have to be seen to be correcting the hypotension or hypovolemia that the children are presenting with, so that we can be able to correct the cellular or tissue perfusion. So we need to give these fluids with caution, like we've indicated, because we stand a risk of overloading these people with fluid, which can end up compromising the breathing that we are trying to struggle with and therefore correct. So we need to be seen to titrate the fluid therapy amply well on the need that the patient is presenting with. And that's the reason why for people that are going to be managed in HDUs and ICUs, routine chemistry tests are very important. So who are the groups at risk of developing severe forms of COVID-19? One is people that are aged over 65 years. This is according to our literature as Uganda. Majority of the people that we have managed in the high dependence units and ICUs, and those that have succumbed to COVID-19 have been the age category of 65 years and above. Though with the second wave, that age category is coming down. Presently, we are standing at 45 years and above. Then people that are going to be having underlying heart conditions will have a high risk of developing severe forms of COVID-19 and therefore should not be treated with ease or with negligently because they can easily surprise us and we end up losing them when we should have saved them. People with diabetes mellitus, people that have cancer and then later develop COVID-19, and people that are being treated for cancer. Then people that have advanced liver disease, people that have advanced HIV or AIDS, and people that have other underlying lung diseases like asthma, TB, and chronic obstructive pulmonary disease with kidney disease and severe acute malnutrition. All these are conditions that compromise a person's health. And when you get a bout of COVID-19, it exacerbates the condition and it could give you a poor outcome. So this slide is very important to us, especially in the private sector, because we've been having a very big challenge as a country where we have a lot of literature that comes in from elsewhere, internationally, locally by healthcare workers that have read wide and come in to inform the response. And we've had people coming in and using different medications that are not cleared for use in the management of COVID-19 as per the national guidelines for the management of COVID-19 in Uganda. So the medicines that are only cleared for use under compassionate protocols or clearance, ivermectin, remdesivir, tocilizumab, and colchicine. Convalescent plasma is one of the interventions or remedies that were studied and were found to have any impact on the outcomes of COVID-19, and therefore people should desist from using them. We have a lot of private facilities that are using these medicines against protocol, and I would expect us under the umbrella of Reproductive Health Uganda, not to fall in the same trap as other people have. So for medicines that have been cleared as no longer important or with any impact in the management of COVID-19, as per the Ugandan national guidelines, hydroxychloroquine, convalescent plasma, vitamin C in adults, and azithromycin, despite the fact that we are still using azithromycin because of some studies that have showed that it still has an element of impact it provides when we are managing, especially lower respiratory tract infections with bacterial infections, secondary bacterial infections, especially people that are having staphylococcus generated or infections, lower respiratory tract infections. So the prevention of complications of COVID-19 during the treatment, for prolonged days of invasive mechanical ventilation, let's make sure that we use weaning protocols that include daily assessment to minimize the length of time a person stays on mechanical ventilation. Remember, the longer a person stays on mechanical ventilation, the poorer the outcome, because they'll have more severe complications arising from the mechanical ventilation, and therefore we should be seen to do everything possible to give them corrective mechanical ventilation for the short time or period they need it, and wean them off so that they can use other modalities. Then we have complications of secondary infections that arise as a result of use of ventilators, or what we call ventilator-associated pneumonias. And this is a clear infection prevention and control issue, because it shows that there could have been an aspect of cross-infection or cross-contamination by the healthcare providers that are handling these patients. So we should be seen to give oral intubation if preferable. If the preferable nasal intubation is not applicable, or high flow nasal cannulas are not applicable. And then we should be able to exercise strict infection prevention and control hand hygiene procedures when we are going to handle these patients, so that we avoid healthcare associated infections. Then venous thromboembolism, we have to use pharmacological prophylaxis. And what we're using in Uganda presently, as per our guidelines, is Clexane or low molecular weight heparin. Then catheter-related bloodstream infections. This is also an infection prevention and control issue, because many a time it arises from poor observation of hand hygiene and procedures, aseptic procedures, when this intervention is instituted. Then pressure ulcers, we need to make sure that we turn patients every 2 hours, and we avoid pressure on areas where people tend to lie or sit for long times on. The pressure ulcers and the stress ulcers, and then the gastrointestinal bleeding, we need to be able to give early enteral nutrition to the patients and administer histamine to receptor blockers to make sure that we prevent the insult of the acids onto empty stomachs, which could end up giving us stress ulcers or gastrointestinal bleeding as a result of those exposures. And then ICU-related weaknesses, we need to be seen to actively mobilize the patient early in the course of their illnesses, whenever it is safe for them to ambulate and get off the beds. So the discharge protocol, I think this will be discussed in, well, okay. It will be highlighted more in the home-based isolation discussion. But for people that are having asymptomatic disease classification, these are people that are no longer admitted into hospital, and therefore there is no need for us to discuss their discharge criteria. But we need to be seen to discuss their de-isolation criteria. When are they de-isolated? We have been having a challenge where many patients test asymptomatic, and they are, asymptomatic after they've tested positive for COVID-19, and they are subjected to home-based isolation and care, under which protocols it's stated that a person should be able to separate themselves from the rest of the family, meaning that you are isolating yourself from the rest of your family members so that you can you can break the chain of transmission from yourself onto the other members of the family. And therefore, if you've been isolating yourself in an appropriate place, which is described as a self-contained room, well aerated, that can only be accessed by you during that time and not any other person. After 10 days, when it is postulated that you are no longer infectious, we need to be seen to de-isolate you from such a setting. But what is happening presently, all of us are aware about this, and the reason why why we could be still suffering with COVID-19 is majority of the people that have tested positive for COVID-19 and have been subjected to home isolation are actually not observing the protocols. So when a person is told go home and isolate, they actually go home and mingle. And that's the reason why there is propagation of the infection, and why we are still grappling with this challenge. And therefore, we should be seen to follow the protocols as has been guided by the Ministry of Health. People that have mild symptoms, after 10 days of symptom resolution, they should be able to de-isolate themselves. And because these are people that are going to still be managed under home-based isolation and care. Then for people that have moderate to severe forms of COVID-19, upon symptom resolution, those people, if the symptoms resolve within the first 5 days of confirmation of positivity, you wait until 10 days before you can be discharged, or you will only be discharged for as long as you are fit to get back into your community and reintegrate. But the viral clearance is postulated to have happened between 10 to 14 days. And therefore, once you complete your 10 days, whichever comes first, if you complete your 10 days and you had moderate disease and the symptoms have resolved, then at that level, you can de-isolate and reintegrate with the community. So what are the actions for us as private healthcare providers? One is whenever we are managing COVID-19 cases, what is expected of us is to make sure that if you are escalating a person from a lower level to a higher level, there is a Ministry of Health referral, COVID-19 referral form that has been designed, and it picks key particular parameters on oxygen saturation, blood pressure, and what the heart rate of the patient is, and what the clinician or the person that is attending to this person at that level deems as a classification for this person, whether it is moderate, severe, or critical disease. That information should be picked on that form, and the referring clinician or healthcare worker should be able to make contact with the facility where you're referring, so that we can be able to have a complete loop of referral, rather than patients that are going to be referred to nowhere, and they end up suffering, and we end up losing them when we could actually have saved them. Then the other challenge is healthcare workers or facilities have been holding on to patients for long and only seeking to refer them when they are critically ill or when they are moribund, and they can no longer be safe for transfer. What is recommended of us as a private health provider or as an implementing partner is to urge all our healthcare workers, once at the facility that you are manning, you determine that you no longer have the capacity to manage the conditions that this person is presenting with, or thereafter, if this person deteriorated, refer this person early enough so that appropriate interventions can be instituted at the next level for a good outcome for this patient. Then referrals should be managed by facilities and not individuals or attendants. Where we have been having a challenge is because people know I work with the COVID-19 at the Ministry of Health, people choose to call me directly that we are sending you a patient rather than making contact with the hospital. And for us to be able to address this challenge, a toll-free number with a clear referral system has been generated, and it's going to be shared with us here, so that at the end of the day, whenever we have any patient that we hope to refer, we can always refer that person through that line or through that system. And we need to make sure that all our facilities are equipped with oxygen delivery capacity, so that in case we take on a patient that will require oxygen to be stabilized as we wait for escalation to a higher center, we need to be able to call these people that oxygen therapy and make sure that they are stabilized so that they can be able to transit to the next level. And we have to make sure that all our healthcare workers, I'm glad we have 66 people online, are equipped with this information so that they can be able to take decisions that are informed for the good of our patients that we're caring for. And this is just a highlight of the COVID-19 home-based care guideline that has been developed. It will be shared with us later in the presentation on home-based isolation and care. So I'll not delve deep into it. And by this, I beg to end here as I entertain any questions that could arise from the discussion. Thank you.
Yes, thank you, Dr. Ronnie. I think this has been quite comprehensive. I'm very sure the workers on the platform available, and also people team have also put a few learnings here and there. So this is the moment we need to have the questions that we still have addressed. So if you have any question, you can bring it up at this moment. So you raise your hand, and then you will be unmuted for you to give your question.
So they can type in the chat.
You can as well take in the question and answer section so that you can give it out from here. So we have Martin here saying that shall we have the please share this after the webinar. I think this is informative. The presentation will be shared with the team. Yes, I think that is it from Martin. I was wondering whether the materials will be shared. Do we have anyone putting up their hand? So as we wait for the members to raise their questions, I can maybe share what I have. Doctor, at the beginning of the presentation, we talked about isolating clients who are coming to the clinic or the facility, creating an isolation point and managing these clients from there. But just to be sure, as you said that for those who are using oxygen, who are out of oxygen, we need to ensure that the paperwork attending to them is fully done because aerosols now will be generated. Which kind of gown will the provider put on? Will it be the same gown, the clinical coat, or or it's a different gown? And then the gloves, are they the normal gloves to be used, or you have a different variant? Still, during the presentation, we had we talked about vitamin C. We said that if the lab tests show that there is deficiency, we can give vitamin C. So what if no test has been done? Can we continue? Can we still leave it out, or someone can manage paper? Then for screening, testing, we also say that once someone has been managed, has had symptoms, had a positive PCR or a positive test at the beginning, so we do not, according to the guidelines, we no longer need to do a repeat test after 10 days if this patient is asymptomatic. So I'm wondering, if this patient is still symptomatic, can we proceed and repeat the test, or we can still go by the guideline and not repeating the test after 10 days? Yeah, for now, I think that is it for me.
When he was presenting on the treatment of my patient is mild COVID. This is the medicine for adults, and that's also children.
The treatment
To the people with mild COVID and the treatment drugs.
So I say about it can be readable. Yeah, that was there. We also have Dora here asking about in case someone doesn't access the drugs mentioned, which are the emergency treatment can someone be given. I don't know whether this question is, in which context this question is being raised, because these are the recommended drugs. And you now find these are non-traditional means which we are talking about. We have what are listing. I don't know whether it is in that context, but these are drugs which have been shared with the team.
Yes, Doctor.
Yes,
mine is what is the minimum oxygen level that an individual should have?
Yes, Lucy.
Thank you so much, Dr. for the presentation. I wanted to ask a question. Can the PCR test be negative or give negative results and then the RDT gives a positive result? I've heard of such a scenario, so I don't know what's possible. The first the PCR is negative and then the RDT comes positive.
RDT positive following a negative PCR. Okay. Out there, we have any more questions? We have one more minute to give it back to Dr. Ronnie to respond. In the meantime, as other people more questions. Dr. Ronnie.
Thank you so much, Dr. Ugololi, and thank you so much, everyone that has asked questions. I'll take the questions in the order in which they were asked. Gowns, which type is recommended for use at holding facilities? We are talking about holding facilities rather than isolation care and treatment facilities at lower level health units. This is in the spirit of continuity of essential health services. So all facilities in the country are expected to have holding facilities in the sense that when you identify or when you confirm a person positive for COVID-19 or when you suspect that the person has COVID-19, you isolate them in that unit to prevent further spread to other people and to the healthcare workers as we work out the mechanism of transiting them to higher levels that have been gazetted for COVID-19 management. And presently, what has been gazetted for COVID-19 management still remains the national referral hospitals at Mulago, Butalika, and the regional referral hospitals, with a few general hospitals that have since been cleared to manage COVID-19. What kind of personal protective equipment is expected? The gown that we're talking about here is a particular gown that has been previously, what people used to look at as personal protective equipment or gear was a coverall that was made of a material that could not permit water and any other small pathogenic molecules to penetrate it. But we have since moved away from that coverall, what we call the hazmat suits, what we've been seeing everyone donning or putting on. Now what we are recommending is the use of gowns because the infection we are dealing with, the pathogen we are dealing with, does not penetrate a person through the skin, but rather through the respiratory tract. And that means through the airways, the mouth, and in the eyes by what we call the lacrimal, the nasolacrimal ducts. That's only how you can be able to acquire this infection. Or the alternative of how you can acquire the infection is if you contaminate your hands or contaminate your skin, and then by not observing good or appropriate hand hygiene, you find yourself contaminating those areas of surfaces that we talked about, the eyes, the nose, and the mouth. Only then can you be able to acquire the infection. So for as long as you are working in an area where you are not going to be generating aerosols by making the pathogen that has been found to be heavy, making it light so that it can pass around in normal air by what we call airborne. In that regard, you can use a waterproof or a leak-proof gown, preferably nylon gowns that have been made. So in that regard, that is PPE level 3 or level 2, where you put on your scrubs when you're accessing a patient area, so that you do not contaminate your clothes that you're eventually going to go home with. You put on hospital scrubs to protect yourself and your people that you left at home, but then also you put on that gown to prevent contamination of other surfaces of your skin or your body that eventually, through touch, you can end up picking the pathogen and infecting or contaminating your surfaces through which the virus can access your respiratory tract. Because COVID-19 being a droplet infection affects the upper respiratory tract, as opposed to TB, which is an airborne that goes to the lower levels of the respiratory tract, that is alveoli level. So with this, we expect it to be in the bronchus upwards. Yes, so we use a waterproof gown that has been made of material as good as the masks that we are using. The blue masks, someone could flash Dr. Golovi's mask. That is the, or Dr. Kukiza's mask. That mask, that same material is what is used to make the gowns that we use to access infectious areas or red zones where we do not expect aerosols to be generated. For as long as we are going to indulge in aerosol generating procedures, nebulization particularly. Nebulization is where you try to, I don't know how I can demonstrate it. Well, what you're trying to do is that you're trying to improve the airways of a person by liquefying or by softening the kind of mucus that is in the respiratory tract of a person. So by the virtue of the fact that you are already trying to make it less humid and therefore acceptable for oxygen transfer between the airway and the airway and the alveoli or the surfaces at which oxygen exchange happens. That process in itself of trying to dissolve that mucus therein changes the format or the state of the medium in which the pathogen is contained from being in a humid state or moisture state to an air mode of sort. And in that regard, that pathogen can now be easily moved a longer distance as opposed to one that could easily be moved to a distance of at most 1 to 2.5 to 2.5 meters. So in aerosol generating procedures, let's use the hazmat suits. Let's use the N95 masks. Let's use the goggles or the visors, and let's make sure that we protect ourselves sufficiently, because in that regard, we are able to, we are able to protect ourselves from molecules, from the pathogens landing on other surfaces of our bodies, where from any interaction of our hands with those particular parts where the pathogen landed, we can pick the virus and transmit it or transfer it into the soft areas that can end up picking the virus and getting it into the airway and starting the whole entire disease process. Steaming. I wouldn't speak much about steaming because I have not delved deep into it, nor can I speak for it. But the only thing I can speak about steaming is against the steaming. Why? Because we are transferring hot, humid air into our soft areas of our respiratory tracts. That causes wounds along the airways, compromising the minimal security that you had of barrier or mechanical protection that the intact airway was providing against the infections, against the bacteria that reside in the airways. So at the end of the day, you expose yourself to more bacterial, you're more susceptible to secondary bacterial infection as opposed to a person that did not actually steam up. So we need to be cautious when we are talking about steaming. Yes, sir. Then vitamin D in absence of lab tests to determine whether we are deficient or not. Yes, by public health standards, you would wish to prescribe vitamin D unto every person that has done a test and it has showed that they are deficient or they're having low volumes or low concentrations of vitamin D in their bodies. But by public health standards, where you cannot afford a test for everyone, what is recommended now is we give it as an empirical treatment, like we gave vitamin C as an immune modulator. Yes. The discharge criteria, 10 days versus symptom resolution. Discharge can be based on two criteria. One, if you're asymptomatic and you complete 10 days, 14 days, you are regarded non-infectious during that time, and therefore you can de-isolate yourself. But if you are symptomatic and your symptoms resolve within the 10 days, then you have to complete the 10 days before you can de-isolate. And if you were symptomatic and the 10 days elapsed when the symptoms are still there, you may be free for COVID, but you may now be having the complications of the COVID-19, which is the lower respiratory tract infections and the whole entire cascade that comes with that secondary bacterial infection. So we need to manage the symptoms or the conditions thereafter until when they resolve. And it's until that symptom resolution that you are de-isolated or that you are discharged.
So about the repeat tests,
you
said after 10 days, you don't need to repeat. You are symptomatic. Now the symptoms are still persistent. You have to repeat or you are showing.
What we have been seeing is by 10 days, majority of the people have actually cleared the virus. And though we're having a few outliers that go even up to 5 weeks before they clear the symptom, before they experience viral clearance. So for a few where we may think that they are still having persistence in their viremia, then we can subject them to the test. That will be able to determine whether they are actually still having active disease or not. But it will not be for any form of therapy, because at that level, what you are managing is the complications with which the COVID-19 has come. Yes. Yes, sir.
Each time we go to ICU, and then the lungs are affected and where oxygen, then comes out of ICU, go to the general ward, is there a possibility that the virus could have got or this person?
If I'm getting your question right, sir, there are two things in that question. One, viral persistence. Then two, when a person clears the virus, how and when do we declare someone non-infectious? Now, a person is considered infectious at the peak of their viremia or at the peak of their infection process or cycle. That is early in the stages of the infection. And by 10 days, we find from the curves that have been studied, by 10 days to 14 days, majority of the people have cleared the virus from their systems, and they are no longer infectious. So for a person that has gone to ICU, you possibly went to the ICU as a result of the complications arising from infection with COVID-19. So while in the ICU, you go ahead and your body will clear the virus. But now it will be the complications, the kidney injury, the liver injury, the lung injury that you got as a result of the COVID-19 exposure that you will have to be managed for until they are able to sustain your life. Only then can you be able to get out of ICU. So even after ICU, you will, once you clear the virus, you will no longer be infectious, sir. Okay, yes, sir. Okay, that's the nice one. So alternative remedies other than empirical, I wouldn't wish to talk about the herbs. I have no experience in herbal medicine. I will not speak for the herbs for today. What is the minimum normal oxygen level? On room air, the expected is 95% and above. On room air, we all should be able to sustain our bodies at 95 degrees, percent and above. Then when is RDT positive following negative PCR? It depends on the timing of the test when it is done. If you do the test, and there are three factors that can determine a result. One, the quality of the sample. Where and when was it done? There are some people who will go to collect a sample and they will collect a poor quality sample, subjected to PCR with its capacity to amplify the molecules that there are in the sample. There will not be any material that will be picked because the sample that was picked was actually very poor. So if you pick a poor sample, even the yield will be very poor. Then two, it depends on the stage of the infection process at which the test was done. If the test is done too early before the viremia has shot up, there are high chances that you may, like if you got exposed today and the body hasn't mounted sufficient, or the virus hasn't multiplied sufficiently in your body for samples to be picked with an appropriate yield, there are high chances that you'll have a negative PCR even if it was done. PCR being a gold standard does not mean that it is absolute and it picks everything. No, it does not. They are what we call negative, false negatives, and they are what we call false positive. So a false negative will arise if you have a poor sample, or if you pick the sample too early in the infection process and too late in the infection process. If you picked a sample when a person was at the peak of their viral clearance, there are high chances that you will not pick the viral material for you to be able to amplify. And that's when results like a weakly positive or indeterminate will come out, and someone will report it as either a negative depending on their bias for the day, or a positive depending on their bias for the day. So that is all of the questions that were asked of me.
Maybe the last one here is around the elaborating further on vitamin C use, especially for prophylaxis.
Vitamin C for prophylaxis has been determined not to have much benefit in adults as opposed to children. So it is still left as not prophylaxis. I'm sorry for having used your word. It's not prophylaxis. No. We are using vitamin C and all these other supportive therapies as immune modulators to boost up people's immunity so that we can be able to combat the virus when we are exposed, but not prophylaxis. By prophylaxis, we mean someone is given medication to prevent them from catching that infection. That is not the case. For vitamin C, we give you vitamin D to boost up the immunity such that should you be exposed to the virus, your risk of developing severe forms of the disease are minimized. Not that we are protecting you against catching the virus.
Yeah, I think that is clear. Yes, please. Yes, all questions have been handled. One was just an appreciation, and the other two have been addressed. So since we do not have any more questions and the time is seemingly not on our side, I think we shall move on to the next presentation.
I have missed it a bit. So, Dr. Is there a strong justification for the prophylaxis which we invest heavily? For example, we know the treatment is vitamin C, zinc, whatever. Then they say, if you are not affected as an immune booster, take vitamin C and zinc. But we've seen people also still get the virus despite all these investments. Maybe an elaborate explanation of whether we should be going to find this, whether that's introduce the severity, and if so, to what extent. Because we've had people get with all these commodities.
Okay.
And they're taking the data.
Thank you so much, Idi. There are two questions in one. Is there a preventive remedy against COVID-19? The answer is none as of yet. None as of yet, because coronavirus is a novel virus. No one knows anything about it. And that's the reason why even the vaccines that we are taking, there is a disclaimer and a lifting of the indemnity by countries that are using these vaccines to say that we are not protecting you. The vaccines we are taking not offer 100% protection, but what is known is they offer protection against severe forms. They may not protect against catching the infection, but what is known is they protect against when you catch the infection, progression, severe forms of disease. Because what we have seen is with the severity of disease, the outcome is also compromised. So if we could keep a bigger number of people that are actually getting exposed to COVID-19 in the mild and at worst in the moderate state or disease state, then we would have better outcomes. And in that regard, the vaccines would have performed their role of preventing mortality. They may not protect from catching the infection, but they will guard against, they will reduce the mortality rate, and by any measure, that is a good outcome. The other was, why is it that when people take all these remedies that we talked about, people still go ahead and get exposed? Like I've already, they get infected, like I've already indicated. When you take vitamin C, when you take vitamin D, when you take the zinc, when you take all these other selenium and anything else that we are talking about today, these are molecules that do not protect the body against the infection, but rather they improve the body's function, immune state functioning, such that when you are exposed to the infection, the body is able to respond appropriately or with much vigor. A body that was distressed because you've taken molecules like selenium or zinc that tend to reduce oxidative stress. The body is left with less stress and with better ability to combat the infection. And in that regard, your outcome is better. And the treatment we are giving to COVID-19 patients is not against the virus, but rather is against the secondary things that are coming with the virus. That's why we are talking about pneumonia, and what we are using are antimicrobial agents, antibacterial agents, rather than antiviral, meaning that there is no molecule that is targeting the virus, but rather the molecules that we are using are targeting the secondary conditions that are arising as a result of the infection with COVID-19. Things like a bacterial pneumonia that is going to be secondary to COVID-19 infection. And this pneumonia, if you didn't have COVID, maybe you would not get it, or if you got it, it would be in mild form. But because you have COVID, it now comes in an exaggerated state to warrant you getting mechanical ventilation or external respiratory support. So we are coming in to correct that state, treat the bacterial infection or the bacterial pneumonia, take it away, improve your lung function so that you can be able to respire normally as the body is fighting off the viral infection and clearing it on its own. So the treatment we are giving in management of COVID-19 is targeting the conditions that are coming as a result of exposure to COVID-19.
So thank you so much for that. So is there any, from your practice, is there any prescription which is best suited, because we have been using from literature, whatever, for prophylaxis?
Thank you so much for that question. And it actually takes me back to my own statements that the guidance that we have does not replace the clinical judgment of the healthcare providers or the specialists that are interfacing with the patients. There is no one-size-fits-it-all protocol. As a clinician interfacing with the patient, you judge based on what the patient is presenting with. Therefore, that's the reason why you will not find antibiotics being given to a person that is not presenting with without a cough. By the time you're given an antibiotic, that means someone is targeting the bacterial infection that you're presenting with. Otherwise, you would not get any medication. A person that has COVID-19 but remains with no symptoms will not get any medication. And if they should use the natural remedies of immune modulators, where you derive vitamin C naturally, where you derive vitamin D naturally from basking in the sun. Vitamin C, you pick it from items like ginger, lemon, and other citric acid fluids, fruits, so that you can be able to modulate your immunity and withstand the infection so that you don't progress. So if you present with bacterial infection in a lower respiratory tract infection, you're coughing and producing sputum, but you are not in any form of respiratory distress, I will give you a different antibiotic. And that's the reason why even in the guidelines that we've shared here, there are different categories of antibiotics or different levels of antibiotics that we have put forth, that a person presenting with a simple cough, if it's a dry cough, you do not have to give a person an antibiotic. A dry cough usually is as a result of a viral infection or something that is irritating your airways. So you don't have to give that person an antibiotic. You'll only give a person an antibiotic when they have a cough that is presenting with sputum production, meaning that it is now productive. So in that way, you are targeting the bacterial infection that is arising secondary to the viral infection, as has been happening around us with a common flu, whereby whenever a person gets common flu, they actually end up many a time, if the immunity is not well maintained or strong enough, then they end up getting secondary bacterial infections. And you find a person having flu and cough. So if a person presents with plain cough, no production of sputum, no antibiotic. A person presents with cough and has sputum but no distress, a simple antibiotic in amoxicillin, and in other guidance like we've talked about, you can give them azithromycin. If a person presents with cough, producing sputum, and they're now starting to get into distress, meaning that their respiratory rate is getting out of the normal, where we know that the respiratory rate is supposed to be less than 20 breaths per minute, someone is starting to get 21, 22, 23. They're having a cough, but then also they're having a difficulty in breathing. Then in that regard, you step up the antibiotic level that you're giving. If you were giving a simple penicillin in amoxicillin, you now give them a boosted amoxicillin by adding another molecule, clavulanic acid. And that is what is recommended. That is a person that is able to withstand oral medication. If that at that level, that person is not able to withstand oral medication, then you give them parenteral antibiotics, either in ceftriaxone or another second or third generation cephalosporin, as has been laid out in the guidelines. Yes, sir.
Okay, sorry.
It's very, I actually feel so glad that you're giving me a platform to clarify. Yes, sir.
Now, what are some of the secondary symptoms post-COVID. Right, that if you are going through COVID and see this happening, then some of the post-COVID
Thank you so very much. You've actually answered the question. It varies from person to person. Different people are going to present with different conditions post-COVID. Others will present with chest pain, depending on the extent of the injury that the COVID caused onto their lungs. Others will have difficulty in breathing, whereby, easy fatigability, whereby just with a simple walk, they start getting difficult breathing because the virus destroyed a bulk of their lungs and they remained with only a small section of the viable or normal tissue of the lungs that can support their bodies. And you find that a lung that was supposed to expand up to, say, 20 volumes is only expanding up to 10 volumes. And by the virtue of the fact that you're expanding up to 10 volumes, that means you can only withstand a certain extent of stress. Beyond that, the body now starts involving or evoking other mechanisms, compensatory mechanisms, so that they can be able to conform. So others will have mental health and psychosocial issues because of separation from their families. So they need to be subjected to psychotherapy. Others will have hypertension. We've seen so many people going into COVID-19 treatment units without hypertension, and they come out when they have hypertension. They have high blood sugar, what we call diabetes mellitus, and there are so many conditions that people will present with post-COVID. And like we said, it's not a one-size-fits-it-all. You manage a person as they have presented, and you tailor your intervention to the condition that person has presented with. And that's why we are saying, whenever a person presents with COVID-19, if they can afford, or signs and symptoms consistent with COVID-19, if you're in a facility that can accord them a chest X-ray or a high-resolution chest CT scan, give it to them, because it will be a basis of monitoring on recovery, on their way to recovery, so that we can know the extent to which the damage was and how we are progressing. You're welcome, sir. Okay, so if there are no any more questions for me, I beg to sign out. Thank you.
We discuss in the protocol at what stage colleagues will file, because we don't want people who are, but now they are specialists and doing patients too long.
Was discussed on the different categories: mild, moderate, severe, and critical. So was clarified.
I think, Doctor, we need to emphasize that one. People, we don't want like traditional bus attendants. We don't want, again, scenario where people hold patients for long or clients for long before the file for higher care.
Let me project my screen.
Yeah, as he projects, I wanted that to move to the next session, but he, someone else will also ask him, when can someone get infected?
I'm sharing, but I think it's in.
When can someone get infected when they have done much? When they have been infected? Also, another question is about COVID. Then you suggest to this system. Someone was asking about COVID. It's very case now that we recommended to use. Yeah, COVID, something in COVID, and also we can come and get reinfected.
Thank you so much, Dr. Lugolovi. I request through you, Chair, that I don't delve into matters that are beyond me. I wouldn't wish to comment about COVID because it's still an issue and discussion and debate. It wouldn't be proper for me to talk about it in this forum. Because speaking from the Minister of Health, whatever I say here will be taken as a position of the Minister of Health. Yes.
Yeah, but maybe to allay the curiosity of colleagues out there, what we are hearing from the media, from COVID is that it's a herbal vaccine. Say, it was derived from herbs which used to treat other related illnesses. And these are just options which are on trial. So it is, I would join the doctor to say that the information out there is not reliable enough for somebody to have a clear eye. But because people have limited options, it is being used in town. And I think that's what has brought the president to endorse the continuity. And the day before yesterday, National Bureau of Standards, okay, it used as a herbal medicine, but not for treatment. It is for managing some symptoms. But the manufacturers were asked to remove the claim that it treats COVID. I think that is what we can take as the position for COVID. But for me and you, people in town are looking for confidence because of the stories which have been mentioned around that. But there is no actual clear-cut scientific evidence to that effect. So you take the decision to use it at personal discretion, but not to assume that it is scientific or appropriate. I think to me that is the general position, based on the information we get from out there.
Thank you, Vicky. It's coming to one. In the interest of time, I request that maybe we can do this session.
Okay.
This will go for that.
This number is actually what I'm saying. That's what I'm saying. Starting the session at this time. This is very important. Let's start after lunch.
So we are stepping out for lunch. Let's have our lunch break now, and then we shall come back. Maybe we are going to make our lunch because the next subsequent sessions are going to be equally long. We start one now, might finish after 2. So the team here suggested that maybe we go for lunch and then come back. So we are going to try to make our lunch maybe 45 minutes and then return for the next session. Thank you very much.
Ngevuddeko naye ndaba wano waggulu bagamba we are in a lunch break. After that you have an option of unmuting yourself if you want to say something. We're in a lunch break. Maybe that's right.
Good afternoon. Hello. Good afternoon, everyone. Kindly mute your microphone the moment you enter, because everyone is asked to speak, so you can mute your microphone.
Nebitasoboka.
What's going on? On here is that done?
And the budget for you. And then after that, we were supposed to be having until actually we have met up with prices. Yeah, but I need to catch up with the officer. Yeah, as soon as the budgets are approved, yes, I have the common position. Yeah, yeah. Yeah, that's right. No, that is fine. That's the way to go. That's the way to go.
So we're ready to start. Good afternoon, colleagues. Good afternoon. So welcome back to the afternoon session. And without wasting time, I will invite Dr. Eno to take us through mental health and psychosocial support. The sessions on oxygen therapy and IPC will still move it forward. So thank you. Over to you, Dr. Eno.
Yeah, thank you, Dr. Ahmed. Thank you, Edith, and the members present. Thank you for the nice lunch. I welcome you back from lunch. This afternoon, we are going to be talking about psychosocial support under COVID-19. You know, COVID-19 comes with a lot of challenges, not necessarily the physical, but also the social, the mental, the economical, so many things comes out. We wait for
First stop sharing. First stop sharing, then share. Are you feeling the slide? No, Dr. Simon, if you're online. But why can't we see from here? Well, that's the only one we'll know where.
So this afternoon, we shall be discussing mental health and the psychosocial support in COVID-19. As I told you earlier, COVID comes with a lot of challenges, which needs a lot of interventions. Not only the sickness which comes with complications, but also the mental part of it. Initially, the mental part of it was not taken before. But when we continue to go to the field and we realize that these people who get COVID need mental and social support because of the stigma and discrimination in the community. So they need real rehabilitation. So our outline, we shall look at the definition, role of mental health and psychosocial support, sources of stress in COVID-19, stepwise assessment and intervention, psychosocial first aid, then community intervention, mental health and psychosocial support for psychosocial responders. Those are our outlines. Then, according to the World Health Organization, mental health is defined as a state of well-being in which the individual realizes his or her own abilities, can cope up with normal stress of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So if somebody gets this disease, I think there is a disruption in one of those. If somebody cannot realize his or her own abilities, then it means is deviating from the normal. If somebody cannot cope up with stress, this is a disease which affects mostly the breadwinners in the family. So once it affects that individual, it is affecting the whole family. So once they are affected, they need support. We don't go to these people to take on the medicine to treat them. No. If you don't treat them psychologically, they will take time to recover. And if they recover with complications. As you heard this morning, that people develop even hypertension, they develop diabetes, they develop the stress out of stress a lot of things comes in. So if somebody is not able to contribute to his own community, then it means there is something missing in that person. Gradually or slowly, as we interact with them, you can bring them back on board. Because we have had diseases which has killed people, like the Spanish flu, the plague, which was even in Uganda here, the first SARS. So you have to restore hope as you give the medication for COVID, you restore hope in the individual and the whole family or community. So this is a holistic care. We don't treat COVID as a disease, we treat an individual. So psychosocial support helps the individuals and communities to heal the psychological wounds. It rebuilds social structures after the emergence or the critical event. It changes people into active survivors rather than passive survivors. When you support them, when you see that what they are going through, you are feeling the same way in what they are going through. They feel you are caring for them. So, like Ebola people were just isolated in the Ebola treatment unit, and sometimes people would just throw their food. That one can stress individuals. And you saw at first when COVID had just come here, yeah? Anytime you test positive, you would see a team in white ambulances. That one scares the community, they scare everybody. And you know, the mortalities we were hearing from outside. Whoever will get COVID will think they will die. And if you don't restore the hope that we wanted you to be isolated, that you don't transmit to the community and the family members, that's why we are taking you. These people psychologically will get affected. Psychosocial interventions include structural counseling. Counseling is really an ongoing process. You, as an individual, as a healthcare giver, you do your part, but you involve the family members also who are close to this individual to help this individual to recover, to restore hope. People die because they have lost hope. And you know, you get COVID, now like the lockdown they are undergoing. People have ordered a lot of things outside. Somebody will just get pressure. They say you are not going anywhere. They say now the customers are not coming to your facility. Or when you have just stopped, you have spent money. But which one is better? Restore hope. After COVID, you will get customers. But if you die, that is the end of you. So we as health workers and the counselors, we need to restore a lot of hope in these people. So if you go now, you will not see the other life. And there is no benefit of going early. Why coronavirus? Coronavirus causes a disequilibrium in the mental health and environment, leading to inability of uncertainty. Now, when you get the disease, you are not sure whether you are going to recover or not. But when you give, we have people giving testimonies for what they have gone through when they had COVID. Those people restore a lot of hope. You know, on this, all the information is all about them. They don't talk about much of the people who have recovered. Every morning you saw your WhatsApp, you will see this one was died, the other one was died. But how many have recovered? Social media is doing a lot of destructive, it is giving destructive information. to the people who developed COVID. I give you an example. The people among the people I'm caring for. A younger man is at about 30 years. He was in contact with the VIP. So we tested the VIP had COVID and he had recovered. He was recovering. So this one is a driver. When we tested him and he had COVID, at first he was strong. Now, as we do our contact tracing, we tested the family members. Among the family members, the youngest boy has COVID, but he has no signs. So we are trying to rehabilitate this individual. For him, he's not worried about himself, but he's now worried about the child, the younger boy. And the children will not suffer a severe disease for the reason you know. But he's worried, so he needs a lot of rehabilitation. And when he observes the child, after 2 to 3 days, when this child is very normal, again he will come up and say, I was going, but now my child is okay. So we need a lot of support. You know, even breaking the news also, there is how it affects people. You know, we used to get just phone calls. You get a phone calls from minister or any testing center and they say, you are positive, where are you? Instead of coming closure, you know that pre-counseling and the post-counseling, it does a lot, but those things were not being implemented. With COVID, we thought only taking them to the treatment units would work for them. But now we need that psychosocial team to be available, to restore hope, to support them. Because even on the treatment, they ask you, apart from this, do you have another challenge which you need to be addressed? They will say no or yes. Yes, I have this one. I'm here. My children are there. They are being chased out of the house. Sometimes you may not have the solution to that, but you say, when you recover, you will go and work and get money maybe to pay the rent. They say, my children are starving. At first, there were some organizations, they were giving support to the affected families. Currently, it is not there, apart from the money we are waiting from Office of the Prime Minister. So these people have a lot of challenges. If you leave them alone, they are bound to collapse. So those are some of the challenges, the broken social networks. Of course, the social network is now broken because we are staying home, we are not interacting with friends. So that one also affects them. Because if the lockdown found you in Kampala and probably your family is up country and you get COVID from here, you will feel you wanted to share something with your family members. However, we encourage them to talk and share their challenge with the family members. If they have positive minds. But sharing, you can share with somebody who is also negative. That one is a big challenge. Then limited access to services. You know, now there is that information that all government facilities are full. When you go to private, you are paying 5 million. And that one also, once you are recognized, it can break you instantly. You say, now I don't have even food. Now I have COVID. Where will I go? Unemployment. You are not getting any income. So you can easily, you earn hand to mouth. We have lockdown. You have COVID. You store those other challenges. So we need the media to get involved in this and preach the gospel of positive. They give positive information. other than focusing on the death, then the limited physical movements. Maybe you wanted to go to the auntie to give you some money, but now you cannot cross from Mtinda to one day find. You see that some people, they will respond to your needs when you see them physically. When you don't meet them physically and explain what you are going through, they will not do what? They will not respond. So those are some of the challenges which lead to mental and the mental breakdown. So we have a reaction.
Normal reaction to a normal situation.
The normal reaction. Normal reaction to abnormal situation. Now corona has come in. How do you react? So what we said earlier, we need to get a way of coping up with the situation is which is not usual. So that is the way how people respond to abnormal reaction. We can start from loneliness. Of course, when you get COVID, they will say you are going to be alone. You are not used to loneliness. How are you going to respond? Quarantine makes it difficult to cope. If they take you to a quarantine, of course, you will always be under command. Don't touch here, do this, don't mix with others. Because in a quarantine, you have like cohorts. This cohort which came today, you are not allowing them to mix with the cohort which will come tomorrow, because you want to monitor them. You know, you allow them to mix. These ones will be recovering, others will be coming in with new infection. So you have people staying longer than the usual. So you don't mix them. So if your friend is like in the other cohort, you are in this cohort, you can't mix. Psychologically not be well. Then no food. We have had a challenge for food, even at home, even in hospital settings. I don't know how you are doing it, but even in hospital setting, you had in the other first phase when the patients were rioting in because of food. Food is coming, but it is not coming on time. Then if it comes, it is not of your choice. Because when you are there, as if you are being helped, you are being supported just, so you cannot make your own choice. You are used to a variety. Now you can't get it. Even the meals which are coming in, probably they are limited to the way how you used to get them. Then children not being catered for. Of course, when you are in these units, you are not giving support unless you have money. You have the ATM, you leave it with your wife or your relative to provide the needs. Then mindset shift from living to survival. Then how do I survive out of this? Then increase the health anxiety. Whatever comes in, whatever minor it is, you will feel it. You know, when you are idle, whatever comes, you feel it. Even the dog barking outside your house, you will not sleep because you will hear it. You get a lot of anxiety. Then hopelessness and helplessness. You may need something which you cannot afford, and people are not providing it to you. You say, am I useless to this society? Why are they treating me like this? Of course, when you are going to see these patients, you are in those gowns, you are touching them with gloves, as if they are not human beings. So that one also affects their mindset. Then fear for loved ones. You say, have I infected them? Now, what will be the outcome? Then we have job insecurity. Of course, when, like what I said, the casual laborers, they will give you money for the days you have worked for. Sometimes if you are not there, they will get a replacement. Now that you have COVID, you are not interacting with them, you are not going for work. So that one also affects your mind so much. Then promotes social withdrawal because you don't want to tell others that you have it. And it is better you tell friends. They also test early and get treated, but you withdraw from them because you don't want them to know that you have suffered from COVID. So those are the challenges which come with the coronavirus in our society. So the role of mental health and psychological support in coronavirus. What is your role? What is my role? Psychosocial support for those affected or infected by COVID-19. Those ones in individual quarantine, which is no longer working, but to some extent it works. Individuals in isolation, when you have advised them to isolate themselves from the rest of the family members, individuals with active symptoms, then family members, health workers, and the community. They need support. So prevent transmission to self and others. That is the gospel we preach. When you get the virus and it is detected early, you do either a PCR or RDT and you are positive. You try as much as possible to protect others. Of course, if you don't protect them, you don't know what will happen to your friends. You can get the disease, you suffer mild disease. Your friend gets it, suffer severe disease. And in the due course, that person can even lose their life. So we need to protect. You protect yourself from passing on the disease as you protect the community. That's why even here we are putting on masks every time, we are sanitizing, because we don't know our status. And in the case of anything, we don't want others to pick from any other member because we are not sure. Then set up mental health and psychosocial support structures at regional and district level. Yeah, we need to set up those structures where possible because the social workers are there, but the challenge has been that all the workload, all the burden is given to that individual. The individual health workers caring for this patient is the one they want to do everything. You go, you give the medicine, then you have so many patients to see. If you have many, what will you do? You cannot certify everyone, but if you increase on the team and you identify the needs, you divide yourself and you say this one does not need medicine, and a social worker go and see this one. But those structures are just being developed. Take care of their own psychosocial health. Whatever complaint they have, address it. There are those ones which are minor and they don't need medication. Whatever they go through does not require medication, though they have COVID. So you talk to them, you say this one, it will go. You get a minor fever, it will go. Then the cough, of course, this cough, even after recovery, people continue coughing. even when they are not what? Infectious. But they want to be on medication. You said, once you finish your treatment course, please don't continue with the medicine. That cough will reduce. Take honey, lemon. You know, you are advising them to take that, but you are telling them to improve. That is nutrition. You are building the immune system to promote recovery. So whatever comes in does not need medication, then you minimize stigma. These people, they are like any other person. Don't isolate them, even after recovery. When the disease had just come, we were fearing anybody who had suffered from the disease, even sitting in here. If they touch something you don't want also to touch, it is not only for those people who are not health workers. Even we as health workers, we were fearing because we had a lot of fear. But now that we know the mode of transmission, then we can protect ourselves so well. Sanitize and wash, put a mask. You will fight it. You know the structure, the cell structure of this virus. It is made of a lipid layer. So once you use this alcohol, it destroys it faster. You use your soap, it is gone. That is why we encourage hand washing. Whether you hand wash 1,000 times, don't get tired. Because when you get this disease, you don't know the outcome. It is still a new disease which can change the dynamics, which can mutate. So we encourage everybody to maintain SOPs. Then take up leadership in mental health and psychosocial issues in COVID-19. Then also to carry out research. We need research. Whatever goes on, we need research. You document what you see from these patients, what promoted their recovery, what worsened their recovery. As clinicians, we need it. Once you document that, you are going to use that to help others to recover faster. Now, like the COVID they talk about, nobody knows how it works, but we are now promoting it. But we give it a try. If it works, then we advocate for it. If it doesn't work, you remove it out of market. That is what research does. It helps you as a health worker to make informed decisions. Source of stress in COVID-19. I think this one. Okay. Please. Okay, we mode of admission. Then we look at the other forum, presumptive in isolation, waiting for results, anxiety about results. When you go to test, you be confident for two things, either positive and negative. So people develop anxiety until they see results, especially now the people who are in advanced age, people in responsible positions. We interact with them. Somebody says, I was almost collapsing, but when you gave me the negative results, I'm now okay. Because these people are planning to fly out, they are planning to meet the president for bigger business. You see that. So that one can also cause unnecessary death among the corporate, this high class. It is affecting them so much. Then strict biosecurity measures among the health workers. Then mass community infection. Of course, if somebody has been a cooperative person, those people who go for social gatherings and one gets or they identify one that has COVID, had COVID, and people attended that gathering, well, those people will develop a lot of anxiety, they become stressful, until some of them go for tests, others they don't want to go. However, the challenge is that the ministry has limited resources. If resources were there, the best way was to test everybody, like under this lockdown. Test everybody, treat them. Because there, the lockdown will be very meaningful. Though it is somehow meaningful, it is reducing the transmission. But if we had added that element, it would have worked. Test everybody. Those ones who are due for vaccination, vaccinate them. You come out of the lockdown when you are safe. But now we shall be going into the lockdown, phased lockdowns almost every year. Because we are going to release people, again they mix up. And yet, if we had used that money we have as ministry to test everybody and treat them, it would have saved a lot. But we shall rotate like that because of the outcry of resources. We cry for resources every time. Okay. Then I think those are some of the critical issues we need to talk about. Unless somebody is not clear. So the stress curve, you can see how it moves. When you become inactive, laid back, then you get fatigue, you get exhausted, anxiety, then pain, anger, then breakdown. People break down, they get breakdown, they break because of the stress. When you get stressed, you become weak. Then you get exhausted because you are not getting enough sleep. The appetite has gone down, which means that even the body metabolism increases, but the raw materials are not there because we get them from food. There you get exhausted, then you start feeling pain, and you break down. So we need that continuous interaction. You know, mental health is the core of almost of everything, though it is given little attention. But it is really very, very important. Okay, step one, assessment of mental health. The dominance of sleep. When you are healthy, you have a normal sleep. Then the concerns, troubled sleep, e.g., nightmares, food tastes like grass or glass. Then when you interact with these people who have suffered even from COVID, post-COVID, they will tell you, they continue dreaming about the pain they went through. Some people start dreaming only about death. When they, so it is really, we need to counsel them on what will happen to them, such that they can avoid those things to happen. Now, the appetite, when you are healthy, it is normal. Then when you are sick, the appetite goes down. Then when you are injured, you lose the appetite. When you are ill, you see complete loss of appetite. Then the mood, when you are normal, you have a normal mood and you function well. Then when you are sick, you become irritable. You become sad. Somebody asks for something small, you bark at that somebody. Then you become angered, hopelessness. then easily engaged, depressed, you go into depressed mood. Then anxiety level, when you are normal, you are calm. You talk as we are talking. Then the concerns, general worries and concerns of frustrations. Then when you are injured, there is decreased performance. Of course, a sick person cannot do. Then when you are ill, you absent yourself from duty or work, social activity, physical health. When you are normal, socially you are well, you are active, you interact freely. Then when you get the disease, there is decreased or tiredness or low energy. Then muscle tension. Then when you are injured, you get withdrawal or fatigue. Then you undergo exhaustion. Then alcohol use intervention. When you are normal, you take a little or you don't take. You know, people say alcohol can relieve you from stress, which is wrong, because alcohol does not take away the problem. The problem remains. When the alcohol goes off, you go back to your normal state, and when yet the problem is still there. So you start from where you ended. Again, you put in alcohol. And alcohol and COVID, they are not compatible, because with COVID, we are talking about boosting the immune system. When you are taking alcohol, you lose appetite. Then also the finances, you are spending a lot of money on alcohol other than on the food, which is going to build the immune system. So when you get COVID-19 and you are an alcoholism, it may take you easily, regardless of your status, regardless of your economic state. It takes you easily. Then you get what? Addiction. So we don't need to go to that stage. We need to talk to our people before, even when they fall sick. That is the information we need to give. The gospel we need to be preaching to the community. You don't solve a problem with a problem, no. Stepwise assessment intervention. Mental health and psychosocial support, assessment and care from point of contact. When these people come to us, you see, especially specifically trained health workers, when they come to you, of course they come with symptoms. When they come, talk to them, you can, like HIV, you can be having COVID or not, but let us do a test. When we do a test, let us accept the results. Other than moving from testing center, you go to this one, you go to the other, and this time there are little places where you go and you get a free service. And even getting that free services, you have to struggle for it. You can be in line for hours and hours just to get a test. So just to know that if somebody has come for a test, he needs the results. When he needs the results, let that person accept and cope up with life. Many people are symptomatic. So those ones, they don't need any medicine. So as they come, you get a chance of interacting with them and advising them. Even before they come, they take a test. The challenge we have, health workers are few. Health worker as a resource, they are few. When you say, I'm going to test, you come, they fill the form, they say, we are going to use the nose or the mouth. They take off the sample, then you go. Are you seeing that challenge? You don't even talk about that procedure. Maybe when we do a swab in the nose, you feel some pain. somebody will just feel that prick, maybe for the first time. So that is the time we need these people to counsel them, and they become our ambassadors to tell others. You get also a chance to talk about SOPs. Then it follows for admission for comprehensive care. Of course, there is a way, there is a referral system. If they come to you and they are moderate, mild to moderate, you tell them you can be managed from home. Like how many people are you in the home? How many bedrooms are there? Now, will you be able to stay alone without interacting with the rest of the family members? Others will say yes, others will say no. Those ones like for Kampala who will say no, you take them to Nambori. Of course, in Nambori, there is no space for mild and moderate. They are those immediately after testing, they want to rush to Nambori. And when they reach there and their chest are away, you see that trauma. They say they are not caring for me, but the space which is there is for critical ill. So that one means that the person who interacted with that client didn't do much in that client. Of course, when you tell them even the options, because when you come to Murago, there are those ones who are critical ill, you are assessing them for admission, then this one is okay, you will automatically just chase that person because you are overwhelmed, the workload. Also, you break down the health work also need psychosocial support. So you start backing up. Then they call you a bad person. Then also we need to have a follow-up. We need to have baseline. From the time, the first time you saw this person, you do all the assessment, the mental, the physical, then you see if I admitted this one. Of course, we take the weight, the BP, all those other things at the baseline, even before you admit them. Then you monitor their progress. You don't do that, then you will have no starting point and you will not have any ending point. So you do that the stepwise assessment and intervention from the time you interact with this patient up to the time this person is either exiting the hospital or exiting from the home-based care. When you are allowing them to interact freely with other family members. Okay, step 2, brief psychiatric assessment and intervention. Then the injured one and the ill. Of course, some people, they can injure themselves. Some people commit suicide. I also saw a younger boy, after testing COVID, he had mild COVID. They went to the facility, they were treating the malaria, clinical malaria. These days, we don't treat clinical malaria. When you do the test and it is negative, don't treat somebody, don't give anti-malaria. So we did the COVID test in the family. 2 were positive, a younger lady and a younger boy. So a younger boy became depressed, so much depressed, because he was fearing the family members to know. Secondly, he was just being supported in Kampala here. He was not staying with the real family. So he was in fear that maybe they are going to chase him away. The guy was okay. The guy walked up and recovered quickly. This boy developed the psychiatric problems, started jumping over the wall that he wanted to walk away, and where he came from, it is 1,000 kilometers from Kampala. So we went, we gave those the tranquilizers. And we calmed him down. He settled, now he's okay. But he just needed people to talk to, because some of the colleagues he associates with disappeared from him. They isolated him. So it affected him. So when you do it early, it does not become complicated. When you do it late, they injure themselves. Somebody said, let me take my life. After I have this disease, I have no hope of recovery, let me die. Anti-COVID people recover. Thousands and thousands recover. That is the message we can give to the community. Then management will refer accordingly. When you assess at this level and you see that you can't manage, you refer, because the referral is part of management. You refer. So step 3, leave for referral for admission. Some client or patients see they need referral. Those referrals are there, and the president also talked about it. Those ones who need is referral call for ambulance, but they put fuel. So the fuel element of it maybe can cause what? The psychological trauma. We need the ambulances. When I need it to take it for free. But who is going to sustain that? I think that could be part of the government or the partners to help these legal people. Linked with case management, surveillance, and in the case of mental problems. But Tabitha now has started treating the COVID, so I don't know whether it will still remain a mental referral hospital. So you realize, you know, the other referral form, you capture all of the information and the reason for referral. Then step 4, how is the patient coping up? We need to make a follow-up on our patients. The challenge we have is that we have a very busy schedule. So when we refer, that is where we end. But if the patient trusted you and came via through your facility, please endeavor to make a follow-up, make a phone call for where this person has gone. Find out. If you have time, you can go there. Then community reactions. Of course, how does the community react towards this? Some people were neglected. They are abandoned in the community. And this one happened mostly in the first phase. The first phase, if people knew that you were coming from outside, you were returning, they would report you. They thought all returnees had COVID. And the COVID we are having, which is disturbing us, it was not from returnees. It's the trucker drivers who were allowed to come in and mix with the community. So people would reject you, they would come to your home, they would chase you away. Even when you have recovered, they wanted even to isolate them, which was wrong, because you can get completely covered out of this COVID. If you suffer from it, you get completely covered. And when you maintain SOPs, you may not suffer from it again. So reducing stigma in the general population. Don't attach COVID to a tribe, political group, age, race, or socio-economic status. Don't say the yellows, the greens, those are the people. Oh, the Bagada, the Basoro, and then because everybody can get it. So acknowledge people affected by COVID-19 have not done anything wrong and deserve your support and kindness. Of course, this one will get it like any other disease. This is a flu, a respiratory tract disease. which you can get from anywhere. Don't refer persons diagnosed with COVID as COVID cases or COVID victims or COVID families, or them by their names. Surprisingly, 2 weeks ago, I went to that side of Ginger. But when they were directing us, they said, you ask you ask for where they buried the COVID what? The family home where they buried the COVID patient. When you reach that stage, you ask for this. And that's what we also did. And they directed us so well. So you see how communities label people. COVID what? So welcome persons who have recovered from COVID-19 back into the community without discrimination. And love them, they are still productive. So we can continue. Management of COVID-19 related stress in general population. Educate people on how to cope up with stress. Talk and ask people from the family, trusted friends, mentors, and spiritual leaders, stroke religious leaders. You get the people they trust to reunite these people in their societies in case they are being disturbed. Talking about their experiences and feeling to loved ones and friends. Of course, when we share those challenges, the feelings, you will help others to be strong. You say, when I went, they managed me, they advised me to take on medicine, I did it, then a few days I recovered. We're encouraging others such that when they get the disease, of course we have peers. In HIV, we have expert clients who talk to their colleagues for what they go through on adherence, and others follow. Even these ones, instead of discriminating the people who have recovered, we use them as expert clients. So teach people to manage stressful experiences. Acknowledge that it is understandable to feel anxious and worried in the current situations. Reduce exposure to distressing news, particularly prior to sleep. Now you are giving information, hey, your friend, do you know this one? Now you are calling the person who has COVID, and you are telling him or her that your friend in Guru has died. How will this person sleep? The nightmares will come and I think, for me, I think the social media should remove those things because they are stressing people so much. Somebody says, I'm here, but now my neighbor has died in the village. Probably I'm going to that stage. And I was already treated, and this lady, you find her in the morning, she's okay. When it comes to evening, because they were sharing information, then they called you even beyond the midnight that she's bad off. When you check for oxygen is okay. You check the blood pressure is okay. All parameters are okay. But she's complaining of things which are not there. But because of the information, that information being sent to her, your friend has died. Now, reduce exposure to distressing information, particularly prior to sleep. Relax the body and mind, practicing slow-steady breathing and muscle relaxation. We encourage these people to do some exercise, especially in the morning and evening. When you do exercise, you are helping the body to recover. At the same time, you are going to get tired. When you go back, you will just sleep the whole night. You will wake up the following day. So we encourage that exercise. It is very good. Then engage in and enjoy present activities. Of course, those activities may not be very practical, like they can play football with the rest of the family members, like that, to make them active, such that they go back to their beds when they are exhausted and get enough sleep. But when you leave them just to stand, to sit, watching the news, bad news, by the time it comes to night, they are already stressed. They will not again sleep. So, we can continue. So, educate on unhelpful ways to manage stress. Discourage reliance on tobacco, alcohol, and drugs. Avoid constant worry. Encourage reunion. Those are the things we are supposed to do. Like what I said, alcohol does not take anything. And even when you are sick, you are weakening your body unit. When you are smoking, you are again injuring the respiratory system. And this disease affects the respiratory system. You see that? So you will discourage all those things. Whether you are sick or not sick, we discourage it. Because there is nothing good from tobacco, nothing good from alcohol, other than making them nuisance. So, I'm sorry if my participants take see that. I'm sorry for offending. But that is the truth. So provide psychosocial first aid. When you see somebody deviating, give them time. These are the people you don't rush. Sit with them, they will tell you their problems. Where possible, you can solve them. Where not possible, you restore hope or you refer to another level. They need a lot of time. Those families which have COVID patients, they need time. If the husband is sick, now everybody becomes sick in the family. And you are now the savior. Who is going there to treat the father or the mother in that family? So if you don't talk to them and give them encouragement, you restore hope, the other person will be going down. You know, this thing, pulsoximetry, it has solved a lot of problems. You measure the oxygen and you say you have enough oxygen. Now what do you want? Stop complaining, over complaining. Those things will go. There is no disease which they treat that very time and it disappears. No. Even removing a jigger from your foot, you will continue having that pain for some days. What about this one which leaves some damages on the lungs? You see that thing? Then provide accurate information about COVID infection and risk. Encourage the use of practical ways to cope by relaxing the body, often by doing things that work for them, like listening to music. Gospel music restores a lot of hope. Though churches are closed, but people can see their pastors over the screen. They put on the stations, the TV stations, the radio stations of their own choice. Then it restores hope. Take them to take deep breath. Then stretching, meditating, or praying. Encourage them to talk about their experience and feeling to loved ones and trusted friends. If they don't talk about their feeling, they will continue thinking about it. If something hurts you and you don't talk about it, it continues paining you. It is until you share with somebody, that's when it will go. And you can talk to somebody who also has a similar experience like you. So you can share and you are at the same line. And somebody will tell you, this one I did ABC. So don't worry. That is a very minor thing. So that one will restore a lot of hope into the family or the individual affected with COVID. Then encourage them to be their own advocates by speaking out about their needs. Encourage connection with others by reaching out to people they trust in order to relax anxiety, depression, loneliness, and boredom during social distancing and quarantine. Of course, when they are WhatsApping, let them encourage them to WhatsApp with people with positive minds. If they can WhatsApp, they can talk. Even people, when people are in the CTU, they go with their phones such that they can continue talking to their family until this person is severely ill. That is when you discourage them from talking on the phone. But if they are not, give them their phones, they continue talking. Because once you move away from your family members, people will think you are going to die now. And you know, COVID, you are there alone. None of your family members will see you until you recover and you are discharged. So every time they call and maybe the phone is off, they will say, now this one is gone, finished. They start crying. So you encourage them to continue talking. Okay. The technique of psychosocial first aid, human supportive and practical assistance to follow human beings who will have suffered exposure of life-threatening events. This will include, among others, assessing the needs and the concerns, like what we said. You ask for other needs. Apart from the illness, do you have any other need? They will tell you. You as a health workers, if the need is some money, some money for the family to survive, you can give them. If you have 20,000 and you give this person and he sends, or you send, oh, this person will feel is still needed in the society. Helping people to address basic needs like food, water. Those are so critical. Because if you are in a city and people, they don't have water, they don't have what to eat, of course the stress will kill you faster than the disease. Listening, but not pressuring people to talk. You listen, you don't force somebody. If somebody does not want to tell you something, don't force that individual. Maybe does not have a trust in you. So is building that trust first. Give them time. But people will ask you, they ask you this question, they ask you the second one. So comforting people and helping them to feel calm. Helping people to connect. Helping people connect to information, services, and social support. Of course, if there are some NGOs giving some support, connect to those families. They need the families. The other time was it World Vision. For the first time, they were helping some of the families with food. I think with some little money, protecting people from further harm. It is your role as a health worker, as a social worker, to protect your clients. So as far as possible. Acute distress should be managed without medication, following the principles of psychological first aid. Like what I said, not all problems are solved with medicines. So you talk to them and you see how you can solve. You can help them. Okay. So psychosocial first aid action principles. Look, prepare, listen, and lead. You look at the individual, you prepare, then you listen. After listening, there are things you can manage you as an individual. If you can't, then you lead. Either to home or to another level, like that. Then somebody will feel he has been helped. So the principle prepare, learn about the crisis events, learn about the availability of services and support, learn about the safety and the security concerns of the individual. Then when you are looking, observe for safety. Of course, some people become suicidal. So you remove from the surrounding anything they can use to injure themselves. Observe for people with obvious urgent basic needs. Then observe for the people with serious distress reactions. Then listen, make contact with people who may need support, ask about people's needs and concerns, listen to people and help them to feel calm. Then link, help people address basic needs and access services. Those ones who need referral, please help them to go to another referral. Help people cope with problems. Of course, now like the lockdown, which is not going soon, you have nothing to do about it. You need to learn how to cope with it. Then give the information. Whatever they ask you, give the information because you are an expert. Then connect people with loved ones and social support. Others may not even have a phone. Others may not have airtime. You can use your phone, they talk to their loved one, they do a conferencing. They talk and you are making them happy. And once somebody talks to a loved one, you restore that hope and they will think they will be able to meet again. Psychosocial first aid, be aware of other emergency response measures. Know contact information for key service provider, such as health centers, mental health. Those ones, we said we manage them holistically. Somebody may become malnourished. You link them to one gym. Somebody is breaking down. You link them to Tabitha. Then child protection services. If maybe they are abused, that this child has COVID, is the one who brought COVID, maybe the COVID which killed the grandmother. Yeah? You know, those things are there in the family. So you link them to child protection services. Then food and material distribution. Those services, those centers. Psychosocial first aid ending your assistance. Use your best judgment of person's needs and your own needs. Explain that you are leading and, if possible, introduce them to somebody else who can help them the handover. Of course, if you see somebody needs a lot of time and you are busy and another person will be coming, you link them, you say when you enter the city, please check on this patient. Then they will have that constant review. If you link them with services, be sure They have contact details and know what to do, what to expect. Of course, that is what we said. Call up your clients and know whether they have reached where you have sent them and how they are progressing. Sometimes the resources limit us, but we are supposed to do that. But if they are within your area of coverage, you can have a courtesy call on these people. No matter what experience, say goodbye in a good way and wish them well. Of course, you can't stay with them forever. These are sick people. Talk to them, relay their anxiety, work on their concerns, link them where it is possible, then you move away. Then you continue making gesture follow-up on them. Other interventions, the breathing exercise. Breathing exercise, of course, those ones with COVID, they tell them to blow balloons to expand their lungs. You blow the balloons like this in it. You are restoring the functioning of the respiratory systems. Then lying down, they encourage people to lie on their tummies. Though some people have big bellies, they cannot do it, but it improves the air exchange, the gaseous exchange between the alveoli. It improves, but people they can't manage. Very few of us can manage. Then positive thinking, then gratitude journals. Give them journals to read, journals which are going to promote recovery, not to distress them. Talking about how in India people are dying, you are giving them destructive information. You give them the information that now the medicine, now we have COVID-X. You use it, you recover. That is what they want to hear. Give people information they want to hear. Mostly when they are sick. Then community intervention. The goal is to reduce the fears and promote community empowerment and efficacy. Work alongside with risk communication team. Of course, in the community, maybe at district levels, that's where we have the health educators who do risk communication. Work with them. Focus on the psychosocial aspect, and risk communication focuses on communication. The issue about the communities is communication. You are communicating, then you are giving information which restore hope and information which calls for unity and togetherness. Because previously, all the individual concern in the community was a concern for the whole community. Not these days. If you have a problem in the community, it is your own problem. But previously it was, if somebody has a challenge, it is the challenge for the whole community. That's what we need to restore. Then assess those who need further psychiatric intervention, then reduce stigma and support reintegration of recovery patients. These days it has gone down because at least almost every family has had a COVID patient. So that rejection has gone down. People are now working together and they know anybody can get the disease and can recover. Yes. Emergencies are always stressful to respond to specific stressors. Particularly, I think we can just go to the summary. There is no summary. We can go back and where we have ended. So we say the emergencies are always stressful to responders when it had just come. It's not structures were not there. They were not there. Everybody was fearing the disease. Who would receive these patients? Who would do what? It was a lot of disaster. Specific stressors, particularly COVID-19 outbreak, may include risk being contaminated and contaminating others, strict biosecurity measures, physical strain of protective equipment, physical isolation, and adhering to a non-touch policy. Constant awareness and vigilance is required. Strict procedures to follow. Leaving out spontaneously. Then the tension between the public health proprietors and wishes the patient, stigmatization of those working with COVID-19 patients. At first, there was a lot of stigma. The people we started with, I think they dropped in the first 1 week. They never wanted others to know that they are working with COVID. Then they feared to get the disease. Even we who persisted, every evening you would go back with headache. And the headache of the stress, you are not sure whether you have contracted the disease or not. Then also the stress on PPEs. In fact, it was World Health Organization which came in to support us. Otherwise, the PPEs were not even there. Now they are telling you to go and assess the returnees because the focus was on the returnees and you are fearing them. And they were very normal, very healthy. But you will fear, then you will go back when you have a lot of headache. So others dropped because of that. They feared their relatives to know that they are working in COVID and their friends. They dropped. So when something is new, really it comes with a lot of challenges. So practice self-care. Before the response, are you ready to help? How do you know? Build reliance. Of course, you need to have some basic knowledge on the transmission, especially on these diseases. Of course, we had heard about some literature that when you sneeze, you are transmitting it to others. When you cough, you are transmitting it to others. When you touch surfaces, you are going to get it. But now we are not used not to touch the mouth, not to touch the eye. These days you can spend a day without touching your eye. Then sanitizing and hand washing. We are not used. But do you know improving the hygiene has done a lot? Even the other diseases have gone down. Even the respiratory diseases. The cough and the flu has gone down. So now the hospitals, they are remaining to treat malaria, clinical malaria, which is the COVID. That is the disease, maybe the NCDs and HIV. HIV does not attract this in private facilities because what I'm going to say to them, when they get free services, so we don't blame our people getting a lot of money from COVID patient because once COVID goes, what are they going to treat? Almost nothing. Malaria, the mosquito nets we have, so it has reduced. So during the response, how can you stay physically and emotionally healthy? Manage the stress. If there is something, talk to a colleague. Of course, we work as buddies, as partners. You are not going to work alone. Once you find a challenge, share with your colleague. Don't keep it for yourself. Then after the response, how can you take time to rest, to recover and reflect? This is the fatigue which is killing a lot of our health workers. Because you are good, you want to work 24/7. You are going to contaminate yourself. You contact automatically. Doing you can do well. Then when you are doing, when you are doing, you contaminate yourself. And because you are tired, you are in the hurry, you will just go home. Then you go with a disease. And you will not know the outcome. So we need to work in shifts and get enough rest. When you get enough rest, your mind will be sober. You will maintain the SOPs. Yourself first, then you serve others. But now we want to serve others when we are even stressed beyond our limits. It is a big challenge. So before getting ready, learn about the current situation and the roles of the different respondents. Don't go beyond your limits. Because if you are a clinician, you will assess. Then the lab technician will take off the sample. Maybe the lab rider will come and transport the samples. But now you want to be everything. You have limits. Consider your own health and life stressors. Make honest decision about whether you are ready to participate in the situation. If you are not feeling well, say no. Let us learn to say no, even to our bosses. You say, I'm not refusing to do that work, but today I'm not well. And those who listens, we will listen to you and we will leave you. Whatever crisis you are in. If you are not ready, because there you are going to make mistakes, and it can come to you as an individual. When you are not there tomorrow, the organization will get another person to replace you. But for you, the family cannot get another person to replace you in the family. So let us learn to say no. Where you cannot deliver, say, my boss, no, because of ABCD, I'm unable to do this. I'm not telling you to be what? To rebel, but where there are facts, you learn to say no. Be sure that you know how to observe and appropriate safety measures. Of course, if you don't know, you are getting people who are not health workers working in COVID, you have not trained them, they will get sick. And we don't want that. We don't want to lose anybody on this battle. So if people they don't have enough skills, first train them, then you take them on the battle. Don't be like the Rapoina. With 40, 80s, with people who had just water and the sticks to fight people with guns. No, first train them and give them some equipment. If they are not there, do it in a phased way. So during managing stress, health work and life habits, remember what helped you in the past. Of course, we are building when we are learning from experience. Of course, there is a lot of literature. Now, this SARS is not the first time, though it is modified. But how did we cope up? How did we manage the first SARS? You look at the literature and learn. Take time to eat, rest, relax, and even for short periods. keep a reasonable working hours, avoid exhaustion. Remember, you are not responsible for solving all people's problems. There are others who can take up after. Minimize use of alcohol, caffeine, or nicotine, especially when you are going for work. There are those ones who say, if I put in something, I can walk away. Walk away where? Under the influence of something. If it wears off, what are you going to do when you are in the middle of the procedure? You will collapse there and you become another patient. Check with fellow respondents and have them check with you. That's what we say we work as buddies. When you feel you are not steady, tell the buddy, I'm not steady, then let another person comes in to take up your role. Talk with friends, loved one, or other trusted people. Share information with your boss. Say, here, I'm not good. What do we do? I need capacity building. They will help you on that. They will mentor you. They will coach you. So you are not an island. You have to work with people, you consult them, you interact with them, you learn new skills, as you also teach them. Let the workplace be an interactive place. Like that, the fellow colleagues, the boss, the subordinates, like that. There you will manage. Is it done? Then rest and reflect. Talk about your helping experience with someone you trust. Acknowledge what you were able to do to help others, even in small ways. You share the challenges. You share. You say, here, I did ABCD, but the patient recovered. Then you are helping others learn what you did, if it was good. If you do something wrong and the patient dies, still you will not talk. But if you can share with them something, they will guide you and say, here you did bad. You would have done like ABCD. But we normally share only the good outcomes. But once you do something bad and the patient dies, you decline to say anything. You can even say, I did not see that patient, which is very bad, because we need to correct one another. So take time to rest, to relax before resuming the work. Like duties. When you relax, you become sober. Mindset shift during the pandemic. I will get sick. Of course, that's what I told you. You were also fearing to get sick. Respond when necessary. PPE is available. Make proper use of the appropriate PPE. We were using that coverall just for screening. You use the cover, which is very expensive. You put the face mask, the goggles, the what? So anyway, it was because of fear, it was a new disease, but we are also wasting resources. I will contaminate my family. Further, monitor the signs and symptoms of COVID-19, then self-isolate. So whenever we get headache, you go for a test. And the test comes out negative. Then you say, okay, because there is that cortisol. Every after 2 to 4 weeks, you take a test if you are working with COVID. Even if you don't have any symptom, you run a test. Because services are there, they are available, but it is some are also wastage of resources. I will be stressed and burn out. Monitor signs and symptoms for stress overload. I will maintain my social network, family, and exercise. Some days when you are off, relax, be with the family. Do some exercise with the family members. You know, people get a lot of support from the family members because you are very free with them. So you get a lot of support there, even at the workplace. So I think maybe if there are some questions and answers, let them be forwarded and we share. They may not be directly coming to me, but to any of us, because you have a vast experience in managing the psychosocial issues.
Thank you very much, Dr. Edo, for the wonderful presentation. Colleagues, it's a question answer session now. And feel free to post your questions to the chat. And for those of you who want to ask your questions directly, feel free to raise your hand. So we'll look into the chat and see if we have any questions there.
So as the colleagues are coming, I wanted to state that you know how take people through. We have been quite elaborate, but most of the areas where you encounter, I like the way you even address the his colleagues, the possibility to be there. I think that's good. Appreciate some of the literature. That's part of this literature. But I had a specific question. One of the suggestions we made was exercise to encourage breathing, support breathing. I wanted to know whether that exercise, if your lungs are affected, will you be adding stress to the already affected lungs? If, for example, you're operating at 20% in the lungs, and yet here you are supposed to, will you risk collapsing? That would have been something. Yeah. But it's very, very stressful, like you mentioned. Question. If your whole family is down, there is need for a unique approach like families where the whole family, father, mother, children, they can support themselves. And here, take now the parents to hospitalization. For children, I think that is one of the most one we should know. Social support programs. I don't think we are doing enough families who everybody gets the virus and moves to maybe the severe cases.
Okay, thank you, Edie, for that question. The next question will be Fresh. Your hand is up.
Thank you very much, Doctor, for the
Please
presentation.
go ahead with your question.
Okay, am I being heard? Am I heard, Dr. Annette?
Yes, please go ahead, Crush.
Okay, thank you very much, Dr. Enoch, for the presentation. For me, I think as we discuss issues around the mental health We also need to look beyond the person who has been infected or has been diagnosed with COVID, but even the people around him, as partly mentioned by Indy, but also critical to mention are the young people who are currently out of school.
You might need to repeat the question for the facilitator, the volume might be low.
Okay. Okay, probably let me type in the chat.
Go ahead, Crush.
It's typing in the chat. It says it's typing in the chat.
Is there another, can we use one laptop to reduce the echo?
It's working, but you know, it's controlling them as well.
Then can you?
It's okay.
It's okay because of the echo. Then you put up yours. Okay, Raj, you can come again.
So you must take.
Creation control.
Just a reviewing of exercise. And exercising before someone contracting the infection. Does it also support in boosting the preparation for possible infection? And then I was also curious for those who serve the COVID-19 patients, when returning home, I know you have been doing, how do you handle the attachment at home? Is it a normal process or there are some steps to take?
Okay, just open the chat so you can put some of the questions there.
Raj has shared this question. How can one support a person who is in denial? A person who is in denial, some people may be diagnosed with COVID, but then they refuse to self-isolate in fear of getting stigmatized. That was Raj. And then someone here is asking, update us on the nutritional component typing to provide COVID patients in different cases as you stated. So far, yes, thank you.
Then there's a hand from Martin Obuti. Yes?
You don't speak.
Martin,
The hand has been up. Okay, Martin, if you can hear us, type your question in the chat and they'll be addressed in the next round. Maybe over to you, Dr. Eno, to answer what you want to say.
thank you, Dr. Ahmed. So the question from Eddie about exercise, especially when the lungs have been affected up to like the level of 20%. When we are starting exercise, we start slowly. And exercise helps the lungs to recover. So you give small exercise until you monitor. Of course, this patient will be coming in for review. So every time they come and you see improvement, then you add on. Like what we said, from growing a balloon, you can even increase on something bigger like that. until when people start even running, you run and do exercise. You don't start with a big exercise, you start slowly. And you know, exercise promotes healing. You know, of course, if you had, let us say, if you had a fracture and maybe the hand has been unsealing, you leave it so for so long, it reduces in size. So to restore the function, you start the exercise slowly, until it regains the normal function. So we start slowly as we monitor. So the next question was on social support mechanism, especially when the whole family is like affected. You know, the ministry has not developed a real mechanism for this because of one thing, the resources. However, there are some, we call them coverages, assigned to different individuals. These individuals are very few and they are overwhelmed. So they may not satisfy well the families because of that challenge. Because you have to facilitate somebody, you give fuel, probably you give allowance, then it requires a vehicle. So somewhere, I think maybe we need the partners to support the Ministry of Health to strengthen this. But this that social support mechanism, it works better than even taking these people, taking them to city, to treatment units. For me, I believe where we are going with my colleague who was here, we discussed it with the Director General. And the final phase is that they allow partners to support home-based care. Because as a ministry, it cannot on its own. But when the partners comes in, of course the partners, another will come and say, for me, I will give the allowance. Another will say, I will give fuel. The other will say, I will give PPE. Other than robbing the ministry. So that one, we are working on it. I think one time it will be fully supported and we increase on the workforce and we can monitor those people very well with time. But right now, no. Then Dr. Simon asked about exercise before you get sick. Exercise is good. Of course, you know it very well. We have a challenge of sedentary mechanisms. You are from home, you enter the garage, you drive up to office, you sit the whole day, then you drive back from garage, maybe to the bathroom, then to the sitting room. You are lowering the body weight. And out of those sedentary outcomes, we are getting increased NCDs, like diabetes, hypertension. There was a time I was driving almost every day, even a small distance. But when I took time without a vehicle, the way how I could breathe, like moving few meters, so things were going bad. So exercise is very good. It improves on your health, it boosts the immune system, so it protects you. Even when you get the disease, you will not suffer a severe disease. You will suffer mild disease. Even now, when individuals are sick with mild and moderate, we encourage them to do exercise. Mild exercise, walk a few meters. When you feel you are tired, come back home. We don't want to stress them so much. As you are breathing in and out, you are doing the respiratory exercise. So it promotes recovery. We like it so much. Then you talked about dosing. You talked about dosing. How do these individuals who work in CTU protect themselves from contamination as they are moving the gadgets? Anyway, that one is under IPC, but still,
This one was on returning home.
in returning home.
No more clothes.
Because now there is a way, because when you are from CTU, whatever you do, what you put on last is what you remove first. You see that? So every time you remove, maybe the face mask, you have to wash hands. And is it 0.1%? 0.5%. You wash hands, you wash every time. Then you step into the basin is deep. Then sometimes they can even spray you with deep, that you don't go with any possibility of carrying the disease. Then we remove these attires. Then you put on the hospital gowns. You know, those clothes like what you put on when you are going to the theater. You put on those clothes, you remove this one and keep them separate. So even those ones you have removed, when you come the following day, of course they take them to the laundry for washing and ironing, such that we reduce any possible contamination. So that is the way how we survive. But we shall see that, the donning and doffing, in the next presentation. Okay. Another person asked about how can you support somebody under denial? Yes. For fear of getting a student. As we said, we need to engage the trusted friends. And if somebody say that he has COVID, must have his test results. Of course, you can't deny what? Facts. If you tested and the results have come out positive, how do you deny? You can deny, you have the right to deny, but the facts will remain, you have the disease. That is when we engage. We need to engage the family members and the trusted people. Because people deny because of stigma, as we said. Secondly, they are not feeling any sign and symptom as it used to be. But maybe they tested because of other reasons, like moving out, seeing the president, like that. So you get somebody trusted, a trusted member or a close friend to that individual, to counsel the individual, then you show them the results. But what is important in such a person who is denying, probably if he doesn't have signs, you tell him to maintain SOPs, that he cannot pass on the disease to the friends. Because for he or her may not need medication, but we need to protect the colleagues from getting infected. That is what we need from that particular individual. I think I have answered it well. Yes.
Thank you very much, Mr. Eno. Colleagues, are there any questions still?
One last one here.
We have one. Let David go on and then we'll go to someone else.
Thank you, Doctor, for the presentation. There's been a lot of instances where caretakers refuse to enter uninstituted care, take care of their sick person. What is your comment about it?
Yes, someone here is saying that is there how best can students or children, students or people be supported at home, those who are going to school and now at home. For example, someone was enrolled in S1 in 2019, and up to date 2021, we are still in the same class. How best can we support them psychologically?
Any other question from colleagues online? You have a question, type it to the chat or you could raise your hand up. You don't see my hand, I think you can respond to those and we wind up, it's coming to 4.
Okay. Then you asked about the caretakers being prohibited from entering CTUs. When you are in COVID treatment centers, we don't want you to get the disease. When you go there, you are at a risk. Of course, even the people who work there, they put on a lot of protective gears. You as a caretaker, you may not be able to afford. So in a way of protecting the caretakers, they are being stopped from entering the CTUs. You know, when we are sick, we need support from the relatives. But now this one is a highly infectious disease. We rather leave you remain healthy, other than coming in, you get the disease, because many people have been treated and they have recovered. And what is important there are the health workers doing the right thing. Yes, if they are doing the right thing, it means many clients or patients who are admitted, they will recover. So we don't need a caretaker inside. However, when you need communication, as we say, the patients are left with their phones. You continue talking, and we allow him support, like food, like water, whatever you want. You can request from outside, they bring at the hospital, they give the health worker brings that material to you. So we do that in the interest of the community. We are protecting the individuals from getting sick. Because you come into them, another person comes in the other day, how many people are going to get contaminated as they support their patient? So many. So we do that to limit transmission. Somebody asked about how best can students be supported. You know what? They are not progressing, they are not moving to the next level, but the good thing, they are helpful. Education, you can get it at any age. Education has no limit. But so long as they are healthy, the psychosocial support they need, they can, that's why we involve the community. We have those committees at parish level, at village level. Whenever they need that counseling, that support, they can get it from the village teams. But what is most important is that these students, they are healthy. You and me, we can also go back to school. But when you are healthy, education has no age. You can get it at any age. Education and wealth, you can get it at any age. So let them not get worried. Hey, they have grown up. Let them be patient. Their time is coming. They will study and complete. This one is about to end. COVID is about to end. Then another one asked about the updates on the nutritional component or the nutritional need of the different individual, the different patients. Of course, we are supposed to talk about nutrition under COVID, but this program is so tight. It needed to be like a full week to complete the whole package. But we assess the nutritional needs of these individuals and we provide that care. We follow the WHO guidelines or Ministry of Health protocols. That is what you follow. There is no new thing because even the pregnant mothers deliver babies when they have COVID, but you follow the same guidelines. Children undernourished, they get COVID and they are treated. So you use the same protocol, the F75 and the F100. You see that? There is nothing new here. We just integrate the services. We are looking at service integration. That's why we said we are looking at holistic care. We are not treating COVID, but we are treating an individual. If an individual comes with malnutrition, we cater also for malnutrition. Then also link them to other support services. Like managing, you link them there. They get food and give them. So we follow the protocol. They already developed protocols. Thank you so much. I'm very grateful to be with you, and we shall continue interacting.
Okay, we need to wrap up. It's getting late. Thank you so much, Dr. Pinnock, once again, for taking time to take us through this session. It's one of those that are very important for the team that is before you. Colleagues, we need to close. We need to close now. And just a few remarks from my side. The training continues tomorrow. We have 2 sessions that we've not been able to cover today. So my request is let's try to keep time and we start at exactly 9. If we can log in a 8:45, so we are able to start at exactly 9, that will be helpful and will help us to cover the other two sessions. It's been longer than probably we had expected, but for a good cause. Let's try to keep time tomorrow so we finish early. We so far have Dr. Simon, how many hard copies of the printers?
Yeah, we have 6. But must be students.
So we do have 34 people who have been able to do that test, but we started 51 with more than 50. Now the rest of the colleagues, this is a final call really. I know you've already attended some of the sessions, but if you can, please go online, and Emma has made it easy. Go online, Emma shared the link, just click on it and answer the questions there. It takes a short time. And then if tomorrow we will not be able to allow anybody else to do the pre-test because we'll be waiting to do the post-test after. So please log in timely tomorrow. And with that, I hand you over to Edie to close the room. Over to you.
Okay, thank you so much. Members, as we have all seen, this has been a very educative session, right from the beginning sessions, and now the session we just had with Dr. Enoch. I think we have learned a lot, and like the other mentioned, it goes directly to benefit us as individuals. So I want to encourage colleagues tomorrow during it's 9 o'clock. 9 o'clock, and we will go up to 1, so that we're able to be very good. So I know it requires sacrifices. We would have closed at 1, but you can see some of the sessions are longer than the others. So let's keep engaged. let's take advantage of this training. On behalf of management, I want to thank our facilitators, Dr. Enoch, who was with us. Thank you so much for the very informative session. Look forward to having tomorrow. So once again, thank you. And let's take care, colleagues, let's take care. This is not the time to relax. You guys have to face until it just complains. But never give up. It will be the only survival for you to see the next day. And like we heard from Dr. Enoch, let's psychologically support ourselves. Let's reduce on the stress on colleagues. Let's identify people who are under stress and see how we support them. Let's give the first aid care. Let's do the best. Otherwise, people could be going through very stressful moments, but they go undetected and it can keep increasing. So thank you so much. And I think we close the session for today. Thanks.
Okay, feel free to exit now and we'll meet tomorrow at 9:15. We will share the presentations at the end of the training.